Hello.
Hello. Good morning, everyone. A very warm welcome to all the esteemed faculty, residents, and other professionals joining for this CME today on addiction medicine. Addiction medicine is an ever evolving field that intersects science, clinical care, and public health policies. Today's sessions will not only reflect new research and practical knowledge, but also real world insights from pioneers in this field. On that note, I would like to invite the chairpersons for our first session, that is on opioid use disorder, clinical and policy issues. The chairpersons for this session are Dr. Manish Thakre and Dr. Bijit Pai. Dr. Abhijit Pai is a professor of psychiatry in Datta Meghe Medical College, Nagpur, and is the honorary secretary of IPS West Zone, co-chairman Social Security Scheme of IPS, and past chairman of the website committee and telepsychiatry subcommittee of IPS. He has also been the past secretary of Psychiatric Society, Nagpur, and has various awards in his name in research and presentations at national and international conferences, and has more than 45 publications in international and national index journals. Dr. Manish Thakre is a professor in psychiatry at GMC Chandrapur and is a fellow of Indian Psychiatric Society and fellow of World Association of Dynamic Psychiatry India chapter, and has major achievements in the field of being president of Psychiatric Society Nagpur, scientific committee chairman of Vidarbha Psychiatric Association, and has more than 20 research publications in various national and international journals. Now, I would kindly request our chairpersons to please introduce our speaker, Dr. Atul Ambekar from AIIMS New Delhi.
A very good morning to all of you. Uh, Today's speaker, Dr. Atul Ambekar, sir. Actually, he doesn't need any introduction. Everyone of us knows his work and the extensive work he does in the addiction field. Still, he is I will just introduce in brief. He is a professor at National Drug Dependence Treatment Center, AIIMS, New Delhi. He has special interest in drug policy, harm reduction techniques, epidemiology, and health system strengthening. He is a Secretary General, Addiction Psychiatric Society of India. He's a member, a board of directors, International Society of Addiction Medicine. He's a member, editorial board, International Journal of Drug Policy, honorary fellow of School of Criminology, Hong Kong University. He has more than 100 publications, including peer-reviewed papers, books, manuals, and monographs. He's a research person and expert for UNODC, UNAIDs, WHO, and INCB. He's a principal investigator in National Drug Use Survey in 2019 and 25 from Government of India. He has received BMJ South Asia Award on a non-communicable disease initiative of the year in 2016. In National Research Center NCD, he received the award for outstanding contribution in 2022. He received distinguished Humphrey Fellowship Award in 2025, Government of USA. So welcome, we welcome Dr. Atul Ambekar sir.
May I begin, sir?
Sir.
Namaskar, good morning. Thank you very much, first of all, the organizers, which means my friends from Department of Psychiatry AIMS, senior colleagues from Psychiatric Society Nagpur, Psychiatric Society West Zone. It's always a pleasure for personal reasons, also for me to visit Nagpur, and especially that I have been given an opportunity to come to this very nice place and meet and interact with all of you. That's really an honor. So, when we were discussing the possible topics for today's talk, my friend Suyog told me, कि, Sir, you must talk about treatment of opioid use disorders. I told him, कि, "Bhai, I know perfectly well that in this part of the country, at this moment, opioid use disorder is not a major problem. But his logic was, and I totally agree with him also, sir, we should start talking about it because sooner or later, this region will also be engulfed by that wave of opioid epidemic, which currently has totally spread out across North India. So, till about 2 decades ago, it was expected that, okay, opioid dependence, largely a problem of Northeast India and some major metro cities like Delhi, Kolkata, to some extent Mumbai, Chennai, and so on. Then came the name of Punjab, Haryana, वहाँ बढ़ रही है problem पता चला. Gradually, by when our last survey showed, it was the entire North Indian belt. So, north of Vindhyas, almost in all addiction treatment centers and facilities, even in smaller towns, you will find that addiction OPDs are predominantly sort of peopled by treatment demand is highest for people with opioid dependence. Chhattisgarh, very close from here. Till few years ago, when I used to conduct some trainings for National AIDS Control Organization, and we were training doctors, psychiatrists for opioid substitution treatment. At that time, it was very difficult to find adequate number of opioid dependent people in Raipur. There were other towns in Chhattisgarh like Bhilai, Durg, to some extent in Bilaspur, who had some opioid dependence, but not in Raipur. But now, my friend Dr. Vineet tells me that their addiction OPD is predominantly composed of people seeking treatment for opioid dependence. So it's really a matter of time before it hits this part of the world, this part of the country as well. And it will be nice if we become sort of prepared for it. Because whether we like it or not, we as doctors know that our clinical practice actually depends upon what we have been trained on when we were learning. So the patients we see during our MD and in our early formative years, that's what we sort of continue to practice. If we in Delhi, while we have done our MD and we have been teaching patient students also, we have never adequate number treated patients of cocaine use disorders. So we can't really gain that expertise. So the clinical experience is important. So I understand that in coming years, I expect that in Nagpur also, it will be nice for us to be prepared for what opioid dependence is and what does it entail, its treatment entails. So basically, just to disclose, no conflict of interest. If at all some brand names are seen, they're not in a pejorative context. I will talk of some clinical as well as some practical aspects. Also, it has been my conscious attempt to make the clinical aspects of presentation today, discussion today, for the average practicing psychiatrist, not for large institute which has a very big inpatient facility and they will be able to manage. Uske alawa, if we are working even in a clinic as an outpatient basis, can we and how do we manage opioid dependence? That's what we will do. So very quickly, we all know opioids, uh, be it the natural opioids like opium or the pharmaceutical products, they are one of the best known euphoriants as well as painkillers. And that's the reason why for literally hundreds of years, we human beings have been using opium and opium derived products for treatment of pain as well as to obtain some degree of euphoria, relaxation, as a treatment for fatigue after a hard day's work and so on. They perform very useful purpose medically, but also they happen to be very, very addictive. And then because of this very severe and distressing nature of withdrawal symptoms, it becomes very difficult for a person dependent on opioids to stop taking opioids. So the typical day in the life of opioid dependent people looks like this. They opioids are expensive, so they do something to buy drugs, use them, come out of the effect, and then they experience withdrawal. And that's where, because this withdrawal and craving, this cycle continues. So somehow, as clinicians, our job is to break this cycle. And since they are so addictive, since there are a lot of time, money goes into using opioids, they do not get enough time to spend on their other productive activities, as well as they are also vulnerable for involvement in illegal activities. So this is the out of all kinds of substances of dependence that we know withdrawal is a property of all psychoactive substances. In case of opioids, these withdrawals are particularly distressing and painful. Very rarely they are fatal unless you have some other comorbidities, but they are very, very intense. So the withdrawals is something like it goes up for about first 3 4 days, then it comes down over next 7 10 days. It looks like a very short period, discomfort of just about 2 weeks. But in these 2 weeks, like hell for the individuals affected. They are it's so painful and distressing, and so strong is the craving that people find it very difficult to not take opioids in this period. These are the kind of symptoms we expect from opioids. For a very basic understanding, opening of all holes of the body. So, right from mydriasis to loose motions, all holes of your body get opened. And opioids are painkiller. Withdrawals are exactly opposite. You have severe body ache all over the body. So this is very distressing. But fortunately, they come down as we saw in the last graph also. And how long this period lasts? About 2 weeks at the most, 10 days to 14 days. Problem is, even after these 2 weeks, their story is not over. For next 4 to 6 months, people continue to be affected by low level discomfort, some degree of craving, some degree of difficulty in sleep. In males, particularly, premature ejaculation and difficulties in maintaining sexual relationships. So, all of this lead to a very, very high rates of relapse. Almost 80 to 90% of patients of opioid dependence, having successfully undergone the phase of acute withdrawal, will relapse over next 6 to 9 months, largely because of these protracted withdrawal symptoms, which tells us that opioid dependence must be understood as a chronic relapsing disorder. And we, the psychiatrist, who knows us better than the what is a chronic relapsing disorder? Our other physician colleagues, they often make fun of us. No? कि तुम्हारे पेशेंट का क्या फायदा ट्रीटमेंट करके, तो फिर से आ जाता है तुम्हारा पेशेंट, बार बार उसको दवाई देना पड़ता है. But this is the nature of illness, right? And hence, opioid dependence also is not typhoid or malaria. With a few days or weeks treatment, it will be fine. It's like diabetes, hypertension. You require long term, in some cases, even lifelong treatment. This was a question asked actually in USA when in early 2000 there was a debate about whether people with drug dependence should get insurance coverage or not. So Thomas McClellan and his team, they actually conducted review and demonstrated that relapse rates for other chronic NCDs and drug addiction in general is almost similar. So there is no reason why you should not be providing all those benefits to people with opioid dependence also or other drug dependence also as you provide to people with asthma or diabetes or hypertension. So what kind of opioid dependence do we see in our outpatient clinics? In general, in India, what we see is our alcohol dependent patients. We often see denial, minimization. The family members are complaining of their problem, but patients often deny or minimize. That's not the case in opioid dependence. In opioid dependence, if at all, there you will find some people, they overestimate, they blow out of proportion their degree of dependence in the hope that doctor will take my problem seriously and give me medicine in adequate doses. There is also high likelihood of involvement with law enforcement because these drugs are illegal. Sometimes it may be iatrogenic in origin, very common in our country for GPs to just inject Phenargan blindly, just prescribe tramadol blindly for any acute pain condition, and then there are vulnerable patients who can develop dependence on it, and we can also see some of the physical consequences of their drug dependence. Management approach is just similar to many other substance use disorders like alcohol that we commonly treat, that there are strategies for withdrawal treatment, and then we need to provide long term treatment for relapse prevention. So what is known as withdrawal management or detoxification, as well as maybe followed by antagonist maintenance treatment, is much more popular, much more easier to do, but it is associated with high rates of relapse as well as high risk of overdose and mortality in case patients relapse. Much preferred treatment in terms of the scientific evidence base of effectiveness is the agonist maintenance treatment, but then it has some degree of practical consequences, practical issues involved. Settings. Once again, there is a big misconception in the society, in the field of our own health professionals as well, that treatment of addiction means admission to a de-addiction center or a rehab center. That myth needs to be broken. Fact is, a overwhelmingly large majority of patients of substance use disorders in general, including opioid dependence, can be treated in outpatient setting as well. It's only for these few indications that we see here people may require inpatient treatment. At our own facility in NDTC, we provide inpatient treatment to just about 10% of patients who seek treatment from us. So 90% of the patient receive opioid dependence treatment in outpatient and they remain just fine. Uh, Again, there is scientific evidence base also, which clearly says that there is no good available research to guide the clinician about the outcome or cost effectiveness of inpatient or outpatient approaches to opioid detoxification. So, even opioid detoxification can also be done, and as per the guidelines, can must be done in the outpatient settings. What are the pharmacological options for it? Basically, people are suffering from acute opioid withdrawal. They will need some degree, some kind of opioids over next few days to weeks to take care of their withdrawal symptoms. And for them, there is nothing better than opioid agonists. So, agonist medications like buprenorphine and methadone, they are the gold standard. They are the choice for treatment of opioid withdrawal symptoms. There may be a role of clonidine type of medications also. It's no longer advocated by most guidelines because it's very painful treatment for the doctor as well as for the patient. And of course, our some of our anesthesia colleagues, they offer ultra rapid opioid detoxification, which is totally unethical and must be opposed sort of very vehemently. Buprenorphine currently available easily in India and happens to be as per the evidence base, one of the gold standards, the best treatment for opioid managing opioid withdrawal compared to all other agents. In our own department, we conducted a a randomized control trial comparing double blind, double dummy. So patient received both one oral liquid and one oral tablet and one sublingual tablet and compared buprenorphine and methadone. And we found that efficacy was almost comparable for acute opioid withdrawal treatment. This must be combined with psychosocial, because if you combine psychosocial treatment such as motivation enhancement, etc., the successful outcome is much better. As far as buprenorphine goes, this is a unique molecule, unique product, and all of us must be familiar with it because it has some very interesting properties. One is that buprenorphine, though is opioid agonist, is much less addictive because the euphoria is not very high. It provides relief from withdrawal, but the anand, the pleasure, the feeling of रॉकेट में बैठ के उड़ना जो हेरोइन में मिलता है, that's not there with buprenorphine. So buprenorphine, that for that reason becomes ideal, as well as buprenorphine has a very strong affinity for opioid receptors. So there is a competition of sorts between heroin and buprenorphine to sit on the opioid receptors, which means if your patient has taken heroin and he takes your medicine buprenorphine also, so there is a fear na, oh, double nasha ho jayega. Like what happens with our alcohol dependent patients. If you are already drinking, don't take my lorazepam. In this case, if he's taking heroin and takes buprenorphine, what happens? Buprenorphine being a partial agonist, but with a high affinity on opioid receptors, it will displace heroin from the receptors. So patient will actually start experiencing withdrawal, discomfort, if he takes buprenorphine on top of heroin. On the other hand, if patient has taken your medicine in the morning and decides to take heroin in the afternoon or evening, they will have no effect because the receptors are already occupied by buprenorphine, which is a partial agonist. So, which means there will be no effect of heroin at all. This is the unique property of buprenorphine, which makes it very, very useful for treatment of opioid dependence. So, the prescription looks something like this on day one. If patient is well counseled, adequately understands the type of treatment, type of disease, what we can start is buprenorphine in this manner, and then very gradually, because we are doing this in outpatient setting. In inpatient setting, if we start like this, it should be possible to bring the patient to zero buprenorphine in 2 weeks, at the most 3 weeks. But in outpatient settings, since we want the patient to be comfortable, and since patient is in outpatient setting, we expect the patient to be ambulatory, working, functional also. This is not taking total bed rest. So those kind of situations, we can go slightly slow in tapering, and over the period of next about 4 to 6 weeks, we can bring this down to zero. Again, there is no fixed sort of prescription regimen there. As per the patient's comfort level, convenience, we can decide the rate of taper. What we must remember is reducing and stopping buprenorphine or all agonists is not the complete treatment in itself. In fact, to all my patients, I tell them that this is where actual treatment begins when the detoxification ends. This is just the phase in which you have tided over your discomforting, distressing opioid withdrawal symptoms. Because if patients in this phase are left without treatment, and if they decide to start using opioids again, they might remember still their pre treatment dose as their usual dose of heroin. But that dose was built up over a period of time by developing tolerance. Now, after treatment of withdrawal symptoms, they have lost their tolerance. So, if they use opioids in the same dose, that becomes overdose for them, and there is high risk of mortality. So all our patients of opioid dependence must remain aware of the risk of overdose and mortality if they do decide to relapse after stopping buprenorphine. The bigger question is this: what happens after detoxification? One of the approach, and these are two very different approaches for treatment, either antagonist maintenance or agonist maintenance. Essentially, both of them do the same thing. Both of them prevent the patient from relapsing to the opioid that they were using again. But what do antagonists do is antagonists such as naltrexone, they block the opioid receptors. So the idea here is if the patient is taking naltrexone and this naltrexone has blocked their opioid receptors and patient decides to take heroin again, they will not experience the effects of that heroin. If they will not experience the effects, वो मजा नहीं आएगा उनको, मजा नहीं आएगा तो फिर से नशा लेने की जरूरत नहीं है. This is how we expect that their behavior of taking heroin, obtaining pleasure, which becomes a reinforcing behavior, that will go into extinction. So the idea is to block the patients from having the pleasure of taking opioids. What this will do is, this will not do anything to help them take care of their protracted withdrawal symptoms. So on naltrexone, patients will continue to experience some degree of difficulty in sleep, craving, it will not help at all. Their premature ejaculation type of symptoms, it will not do anything at all. On top of it, it may have some degree of dysphoria as well. So that's the issue with with antagonist maintenance treatment, and that's why this treatment is actually meant for highly motivated people who have less severity of their opioid dependence. So, typical example, a nursing staff who has become dependent on injection Fortwin because of her proximity to opioids and some pain abdomen. So those are the kind of people, or pharmacist, those doctor. These are the kind of people who will do well with naltrexone treatment. But a rickshaw puller, है ना, एक सब्जी बेचने वाला आदमी, those are the kind of profile which we find with people affected by opioid dependence. They are the ones who would require agonist maintenance, because they are the ones who are involved actually in menial labor. Even otherwise, they suffer from body ache after a hard day's work without opioid dependence. So, in the phase of opioid withdrawal, the pain will be much more severe. So, they are the kind of patients for whom we will require what is known as agonist maintenance or opioid substitution treatment. This word in our country, in many other countries, this is the word popular for this treatment, opioid substitution treatment. What this philosophy basically is, people are using an illegal, unsafe, short acting opioid like heroin, and that's what they are dependent on. Very in many cases it is taken by injecting route, which is a very unsafe route. What you do is, in these patients you substitute the heroin with a medication such as buprenorphine, which is what, legal, safe, long acting, needs to be taken only once a day, and is taken as a medical treatment under supervision of a doctor, nurse, counselor, and so on. So the status of the patient changes from someone being a criminal, doing a criminal or illegal act, to a patient who is currently taking a treatment. Even though in pure physiological terms, he is doing something which is just his providing some relief to his opioid receptors. So and many people then have problems with this. There are many detractors who say, what are you doing? You are replacing one addiction with another. You are substituting one addiction with another. They must understand that substitution here means substitution at the level of receptors. At the opioid receptors, heroin is being substituted by buprenorphine. It's not that in patient's life, one drug, one addiction is being substituted by another addiction. What he was doing earlier was addiction. What we are giving now is treatment. And so the substitution is not in patient's life, but at the level of receptors. There are people who have discomfort with this. पर कब तक देने का? ये तो क्या लाइफ लॉन्ग देते रहने का? This is very wrong. Somehow people find it very difficult to take our medicines for a long term basis. You know? Every other medicine is fine. Right? Diabetes, blood pressure, you can take lifelong. Thyroid, people can take lifelong medicine. But somehow, when it comes to psychiatric medications and medications for drug dependence, it becomes a problem for them. So we need to continue sort of advocate for it. So this cycle we saw earlier as well. This is how the cycle goes in the day of people with opioid dependence. What we do is, our substitution treatment takes care of this withdrawal and craving. So obviously there is now no need to continue taking opioids, and now people have more time to focus on their work. They don't need to spend money on drugs, no need to inject, and they remain safe. So the idea is, your body's opioid need is satisfied by taking these pills of mine only once a day, and next 24 hours now you are free to do whatever you want and rebuild your life again. That's what the philosophy of this treatment is. The primary reason this occurs in patients' lives is because of the duration of action of these medicines. When people are taking something like heroin, they are experiencing their highs and lows 3 to 4 times a day. That's why they have to take heroin 3 to 4 times a day. They are either in the state of intoxication or withdrawal, and in both these spaces, they are not productive. They are really not able to walk around or do proper work. But if they are taking our medicine like buprenorphine, it maintains a steady level, by and large, a steady level throughout the day. And people are neither intoxicated nor in withdrawal. Comfortably, they can work throughout the day. So this is what we can go into all the details of clinical how to provide this treatment, but basically we start this medicine only when the patient is in withdrawal. We initially start with about 2 milligram or so, observe, and over 3 to 4 days, then we titrate and increase the dose and bring the dose to optimum level. Here we must remember, for maintenance treatment, our philosophy is not the lowest possible dose. Our philosophy is optimum dose. And how do we define this optimum dose? A dose on which there is no withdrawal, there is no craving, and on top of it, if patient takes heroin, he should obtain no pleasure. Because if he is still finding heroin pleasurable, that means there is still some vacant seats, some vacant receptors for heroin to sit on. We need to saturate them with buprenorphine. So that's how we sort of build that optimum dose, and then patients are maintained on that dose for months, years to come. I have patients in my follow up. Just yesterday, I was reviewing the file of a patient who entered treatment in 2006. So in next year, he complete 20 years of his treatment on buprenorphine treatment. He's HIV positive, living with HIV. So when he came to us, there were questions about his survival. But in these 20 years, he has not only survived, he has thrived. He has actually got his children married, working regularly, and everything is fine in life. But what has not what has been continuously that he has been on buprenorphine by and large in this 20-year period. So this needs to be continued for a long time. In this while, we need to monitor, we need to keep them in follow up, and so on. As I was saying, duration it's not fixed. It needs to be for many years. Decided largely by whether treatment goals have been met, whether you have again rebuilt your life and you can lead your productive, healthy life without taking buprenorphine. Problem is this buprenorphine tablets that we give, it can still be dissolved in water and injected. And if you use buprenorphine sublingual tablets by injection route, it behaves very differently from sublingual tablets. It's much more reinforcing if it's used by injecting route. But that with that route, its properties resemble some to some extent to heroin. People find it reinforcing, pleasurable, etc. And that's why there is a risk of these tablets being diverted and injected. To minimize that risk, these days buprenorphine comes as a fixed dose combination with naloxone. So buprenorphine naloxone combination, take sublingually, naloxone will not act. It's an antagonist. But if you inject this tablet, then naloxone will also act, which is an antagonist, which will prevent the reinforcing effect, the pleasurable effect of buprenorphine from occurring. So to some extent, this buprenorphine naloxone sort of helps reduce the risk of diversion in injecting, but not completely. In this another study that we conducted at our center, we injected people with varying doses combinations of buprenorphine and naloxone, different ratios. And we found that the existing ratio 4:1 is really not much effective. Ideally, the pharmaceutical industry must increase the ratio of naloxone in it, but that's something for a future policy. In general, for opioid use disorder treatment, our Indian Psychiatric Society guidelines suggest that this is agonist maintenance is the first choice treatment. What determines the effectiveness of this treatment is these 4 Ds basically. Dose must be optimum, adequate, not lowest possible, optimum dose. Longer the duration, better the outcome. So delivery must be as patient friendly as possible, and the direction would be over functional recovery. That's where we need to encourage our patients to achieve not just abstinence but total recovery from drug dependence. But as I was saying, morning sir. Good morning. With your permission, sir, can we continue? Yeah. So buprenorphine does have, as I was saying, potential for diversion in injecting. As sublingual tablets, it doesn't have high street value. Street value means how much in black people are willing to sell and purchase a product. But if they are injected, it does provide a high. But as I was saying, buprenorphine naloxone minimizes, but does not completely make the risk zero. And that's why there are very strict regulations for this particular tablet. And now I come to some of the practical issues. Very quickly, we will conclude this. That these are the questions my psychiatrist colleagues often ask me, particularly in private sector. Can a psychiatrist prescribe buprenorphine? Can a psychiatrist, a clinic or a hospital dispense it? What are the risks involved? And is it really worth it? So let's examine these questions, and some of these questions are based on this IPS guidelines on medico-legal issues for treatment of substance use disorder. This particular product, buprenorphine, it came earlier before 2018 with the specific regulation by CDSCO, DCGI's office, that it can only be provided to hospital with de-addiction facilities, which means it's not available in pharmacies. But even in terms of who can dispense it, only hospital with de-addiction facilities. Problem was this excluded a large number of outpatient clinics that our psychiatrist colleague runs. And some of our colleagues actually they ran into trouble with law. Two of the psychiatrists were from Punjab in 2014 were arrested, went to jail. Lot of advocacy took place. I'm not going into all those details, but some of these advocacy efforts and some of direct work with the authorities actually resulted in the CDSCO giving this direction in 2018-19 that this can be used now by psychiatric clinics and hospitals. Psychiatric clinic means any clinic like where a private practicing psychiatrist running an establishment, they can stock and dispense this to their own patients under the existing CDSCO regulations. At our own center, we take this precaution. For first 3 months, we give people only as a daily observed treatment, and thereafter, gradually with family members' involvement, etc., we start giving it as take home. All this to just minimize the risk of diversion and injecting. If we can ensure that these tablets will not be diverted and injected, there is a responsible family member with the patient, this can be sort of relaxed as well. And this is what our Indian Psychiatric Society guidelines also suggest. So there is enough guidelines and material available to guide us on how to use this treatment properly and avoid the risk of falling foul with the law. So, examining those four questions again, there is nothing which stops any registered medical doctor from prescribing a medicine. So, it's not illegal for anyone to prescribe buprenorphine. Even for dispensing, any establishment may procure, stock, and dispense to their own patient. What they cannot do is to sell it as a profit, because then it becomes a pharmacy that requires a pharmacy license. What are the risks involved? Are there any risk of being troubled by the law enforcement authorities? Absolutely yes. If you don't drive a vehicle and sit at home, you have no risk of facing a challan. If you are riding a vehicle, driving a vehicle, there is a risk कि आपका चालान बनेगा. Even if you take all precautions, you cannot minimize the risk that some police wala will stop me, will find some fault, will demand some bribe or something. So that risk will be there. But that risk, how do we minimize it? All our papers we keep ready, we follow traffic rules, and we minimize that risk. So that's the issue involved here as well. For all practicing psychiatrists, we need to take this our the cost benefit ratio in account, and that's how our colleagues must do is. But just remember, if there is a significant problem of opioid dependence in our area, and we as responsible doctors, psychiatrists are not providing this treatment, nothing stops a SEDG to open a so-called psychiatric clinic, employ a young graduate doctor, a psychiatrist in that clinic, and start dispensing this right, left, and center to the patients in a very unethical manner. So we are actually ceding the right ethical type of treatment to the market forces if we are not taking this responsibility on ourselves. At this moment, it may not be required, but as I was saying, in near future, I expect a much larger epidemic of opioid dependence in Nagpur and in this area. So I'll conclude now. Basically, to do this kind of treatment properly, all of us need to work together. Besides our clinical skills, which are no doubt important, we need to have understanding of the operational practical issues as well, and we need to be able to act as advocates for right kind of treatment with the authorities as well. That's what I'll conclude. Thank you very much, ladies and gentlemen. See you in Adicon in Indore in November.
Thank
Thank you, sir. It was an excellent and insightful presentation with lot of practical tips for all of us in treating opioid use disorder. Uh, any questions?
Yes, sir.
Step other modality of treatment
Mhm.
and what to do.
Okay, matlab, you are saying that if patient do not agree to take other
Other
medicines,
medicine of
right? So basically, the patients need to understand that this medicine serves a different purpose, Other medicines that we may be giving, they may be serving another purpose. But we must also remember, sir, that in many patients of opioid dependence, the kind of mood instability that we see, for which we think that they may require a mood stabilizer, all those needs actually go down once patients are stabilized on agonist maintenance treatment. So there is a relationship with opioid withdrawal, protracted withdrawal, and the mood symptoms. That's why microdosing of buprenorphine is recommended as a antidepressant augmenting strategy as well. But in general, if patients require genuinely a mood stabilizer for, say, a bipolar type of illness, then patients can be encouraged to take both of them. There are always cost and economic considerations involved in those matters. And as I was saying, some patients can do very well only on agonist maintenance as well without requiring mood stabilizer.
They only search agonist for
Right,
the
right.
treatment.
If agonists,
From
if you happen to be that place which provides both of them, that's best deal for them. So at one place, if they can get both.
it is very difficult.
Right, sir. That's it. I understand.
Thank you.
Here.
Sir, initially, basically, there are very few patients of opioid dependence in Nagpur. But when the patient is having the severe type of withdrawal, uh, just we go with this symptomatic treatment, or whether we should use the tramadol or what are the other molecule that we are using?
If the opioid withdrawal symptoms are severe and we are not providing them opioid agonist, I see this as a unethical kind of practice. Right? Pain is the number one symptom which brings a patient to a doctor across medicine. Right? Listen, and here the predominant symptom is pain for opioid withdrawal. And if we are not providing adequate relief from that pain, then perhaps we are failing in our duty somehow. So, as Kam Chalao thing, people can use NSAIDs and some benzodiazepines and some clonidine, etc. But ideally, patients must receive an opioid agonist. If you do not have access to buprenorphine, tramadol is a poor substitute in moderate doses, not more than 350 milligram or 400 milligram plus there is risk of seizures up to 350 milligram.
I can.
Tapering doses of tramadol along with other adjuncts like benzodiazepines, etc. that can be given. Thank you, sir.
Sir, in continuation with this question, as you said, the withdrawal can be usually last for 2 weeks, but it can last for months. So, how long should we continue the painkillers? Is there are
Right.
there any criteria for that?
If our approach is of what is known as detoxification, then we are only providing them treatment for acute withdrawal treatment. If we are doing this acute withdrawal treatment on OPD basis, this can take about 4 to 6 weeks also. In some cases, even up to 8 weeks also. We can be slightly slow there, but that's not maintenance. So with tramadol type of medicines, they are not indicated for maintenance treatment for long term. The idea is they taper and stop, a slow gradual kind of taper and stop, but still there is a definite end point that the dose will come to zero in next few days to weeks. With maintenance treatment, we are talking of a very long term horizon, that your dose will continue on this 6 milligram or 8 milligram of buprenorphine for next 6 months or 1 year at least, and then we will discuss whether to reduce or stop it or not. So approach is similar to how we do antipsychotic treatment with for acute psychosis versus mood stabilizer in bipolar disorder. That's the difference I am talking about, sir.
Yes. Thank you.
Thank you, sir. Yes. Okay, there are two hands I see.
Morning, sir. So I wanted to ask, in my PG as well as from my colleagues in Mumbai, I've heard that there is a increase in dependence of prescription medications like tapentadol and tramadol
Yes,
itself.
yes.
So in those cases also, do you recommend switching to buprenorphine and tapering, or continuing that medication and tapering that itself?
Very good question. People often ask me that is there a difference between uh, heroin dependence, opium dependence, and as you were saying, injection tapentadol or injection tramadol dependence, injection 420 dependence. I tell them, is there a difference between whiskey dependence, beer dependence, and wine dependence, desi dependence? All of them are alcohol. So all of them are opioids. If patient is suffering from opioid dependence, then buprenorphine as a treatment, agonist maintenance as a treatment is indicated. So that is decided by the severity and duration of dependence rather than the product on which you are dependent. So people on tramadol dependence, if it's very severe addiction and causing all kinds of psychosocial problems, agonist maintenance with buprenorphine is indicated, and good outcome has been documented. Thank you.
Uh, Sir, my question is, there are few patients who are doing well on OST for months or sometimes years, and then they come to us and they say that, sir, can this medication be stopped or tapered down?
Right.
So, what will be the steps? Means, should it be done in OPD basis, IPD basis,
Yes, good
and
question. Yes.
what reduction should we do?
Yeah, good question. So one is that first of all, to take a call whether it's the right time to consider tapering and stopping this treatment or not. That's always a mutual decision. Should not be ideally forced by a family member or someone. कि कब तक खाते रहोगे? It should not be guided by ideological situation. That ideally a drug-free patient is healthier than a patient taking medicine. That's the myth we need to break. Sub number one. But if we do determine that now is the time to has come to reduce and stop it, we then start gradually tapering it in the outpatient setting. We come to a point where it becomes bearable, when it becomes difficult, if there is a sense of hurry, urgency, then patient can be admitted for the remaining duration of taper as well, and then it can be made zero. But with this should always be with the idea that if required, then we need to go back again to agonist maintenance. If you find it difficult to stay comfortable, productive without taking medicine, there is a risk of relapse. Then we may once again go back to agonist maintenance in the same kind of dose on which you were maintained earlier. But once you decide in the outpatient setting that okay, now we are tapering to bringing it to complete zero, it may take up to 3 to 4 months. So because taper has to be very gradual, and letting the patients adopt.
Thank you, sir.
Sir,
Oh,
just one question. Sir, the dose reductions, because the what it dispenses the combination, and it comes in fixed combination. So when we try to reduce from one tablet OD, 2 milligram and point 0.5, so how do we further taper down?
No,
Means should we go?
the plain buprenorphine tablet is also available in 0.4 milligram variant.
So we
Right?
convert them
We can
to
convert them
daily
to yeah,
dispensing,
yes, yes.
and then
Not even daily dispensing. A patient who you have been seeing for many months, right, or even years. Why should you worry about giving them जिसने 8 10 milligram लिया हुआ है? When he come to 2 milligram, why do we bother so much about 0.4 milligram का diversion तो नहीं होगा? So you can give them the 0.4 milligram tablets and gradually taper and stop them.
thank you, sir. Over to the organizers.
Thank you so much, sir, for a very comprehensive talk on a very, very pertinent topic. Now I would request our chairpersons, Dr. Manish Thackeray and Dr. Abhijit Pai, to kindly felicitate, sir. I would now request Dr. Ashish Kuthe to kindly felicitate our chairpersons. Now we will begin with our inauguration ceremony, for which I would like to request our organizing chairpersons, organizing co-chairperson and organizing secretary to kindly escort our chief guest, our esteemed executive director, Professor Prashant Joshi, sir, and our guest of honor, Professor Sudhir Bhave, sir, who is the current president of IPS West Zone. I would now kindly request our organizing chairperson, Dr. Suyog Jaiswal, sir, to felicitate our chief guest, Professor Prashant Joshi, sir. I would now request Dr. Preeti Bhute Madam to kindly felicitate our guest of honor, Dr. Sudhir Bhave sir. I would now request all the esteemed dignitaries to proceed for the lamp lighting ceremony.
या कुन्तेन्दुतुषा
I would now request Dr. Suyog Jaswal, our organizing chairperson, to kindly give a welcome address.
Thank you very much, Bhavika. First of all, I would like to welcome our dignitaries, Joshi sir, Bhave sir, Preeti madam, and my colleague Gaurav to this CME. This CME couldn't have been possible without the effort and the collaboration of AIIMS Nagpur, of Psychiatry Society West Zone, and Psychiatry Society of Nagpur. I'm very thankful to my friend and senior, Dr. Ashish Khute, for that. Today, this CME, the whole aim of this CME was associated with what are we doing about addiction medicine in the city of Nagpur. Recently, we have started addiction treatment facility with the help of Ambikar sir at AIIMS Nagpur and with the support of Joshi sir at AIIMS Nagpur. So after that, and then we started seeing that we are getting patients, but the referrals that have to be generated from across the Nagpur after such a facility comes, that we have dispensing for the drugs, etc. That was not something which was very as at a level that we see general psychiatry patients for. So we decided, let's talk about the addiction medicine to the crowd in Nagpur. So when we are talking about addiction medicine, what can we do about it? We can talk about what the policy holds. We can talk about how the addiction medicine practice runs in private setup, how to run the tricky path of indoor management of addiction medicine, and also what are the challenges that people face about addiction medicine, and what are the newer advances in addiction medicine that have come. So with that aim, we decided to organize this CME. So without wasting much of our time, I would hand over again to Bhavika. Thank you very much.
Thank you so much, sir. Now I would request Professor Sudhir Bhave sir, our guest of honor, to kindly address the gathering.
Yeah, thanks a lot. It's a great pleasure to be here today. I think as the president of the West Zone of Psychiatric Society, I must congratulate Suyog for this very well thought of and very meaningful seminar on de-addiction. Suyog is always known for very high quality programs that he has been conducting from time to time. And I think the fact that 2 months back the addiction treatment facility was started under the very able leadership of Dr. Joshi, the executive director. I think it's very apt that this is being held under the aegis of the Addiction Society. Uh, I think there is something called casting coup in movies. So I think what Suyog has done with regard to inviting the speakers is a kind of casting coup. I mean, each speaker is a wonderful speaker, as I mean, seniors know them, all of them. But I think for the juniors, it's going to be a treat. I must confess that I'm a big fan of Dr. Atul Ambekar's talks. I mean, they are very pragmatic, very down to earth, very listener friendly, as we all have heard. And the fact that he has a very soothing and calming, well modulated voice, I think that completes the package. Dr. Malay, the way, is known for his very erudite, fairly exhaustive, and detailed analysis of any topic that he's interested with. And I'm very sure that today we are going to have a treat in the area on which he's going to speak. Dr. Suresh Patil is a great doer. He's a good speaker, but I think he's a great doer. I mean, I have the pleasure to say that under the West Zone, he has conducted some programs in his part of the country which have been exemplary. I mean, a good amount, quality and quantity of community research has been done under his leadership. He is a good expert, a good communicator with regard to de-addiction, and I'm sure. I mean, the combined excellence of all of these speakers, the experience that they bring to today's function. I mean, it's going to be wonderful. I mean, I'm certain that by the end of the day, we are all going to be brimming with many more important ideas than we came in with. So I would again say thanks, Suyo, for calling me here, and thank you all.
Thank you so much, sir. Now I would request our esteemed Executive Director, Professor Prashant Joshi, sir, who is also the chief guest for today.
Good morning to all of you, and it's a pleasure inviting you all here on this or but a pleasant Sunday morning, and on a topic which is very relevant now. As you know, that uh, with respected dignitaries on the dais, my friend Dr. Sudhir Bhave, President of the West Zone Psychiatry Association, Dr. Suyog, who is the head of Department of Psychiatry here, and then Dr. Bhute and Dr. Gaurav Singh. Gaurav is, I think, the first DM in de-addiction psychiatry. and in Nagpur, at least, we don't have a, so it's a new specialty, and he's one of those specialists. And a galaxy of speakers. We have great speakers from AIIMS Delhi, Dr. Atul Ambekar. Welcome here, sir. And there are speakers, I'm told, from AIIMS Raipur and from Mumbai. So I welcome all of you for this wonderful Sunday morning to have a very interactive session on a topic which is very, very relevant now. As you all know that on 26th of this month, we had that anti-drug abuse or the International Day for against drug and substance abuse being observed or celebrated, you can say. And we also had the whole week of activities going on, so being conducted by the police department here, and which again signifies of drug addiction not only by medical specialists but also as an integrated approach or a multidisciplinary approach involving other branches of faculty as well. As we know that police department become very active in organizing and this program. What is very important as this silent epidemic or emerging problem, which is clearly assuming public health importance, which is not very well recognized, is needs to be addressed not only by the psychiatrist or by the general physicians, but also by by the whole public as such. Very important is a lack of awareness, and it's very important that this lack of awareness should be overcome by awareness programs, not only for the laypersons also, and some educative material for the as you know, that's more common in college going and students, and it's very important for the parents to know and to pick up signs of early de-addiction, changes in behavior of their wards, so that early intervention can be initiated immediately. It's also very important that till now what is happening is that addiction treatment facility as has been started here at AIIMS Nagpur under the leadership of Dr. Suyog. These kind of centers are very few. If you can say that there is a big treatment gap, the amount of people who need treatment in a scientific evidence-based manner and the amount of facilities which are available, there's a huge gap.
in say about 80 to 90% gap between what is needed and what is existing. So it's very important that we build up these kind of facilities so that and also this, it's both ways. Not only the facilities are less, but also people seeking this type of treatment is less. So awareness is less. So we need to increase the awareness among the general public, as well as we need to increase the treatment facilities. So it's very important, very nice that we have our Department of Psychiatry has organized this CME on addiction medicine here on the week in the as which is in the week which is the International Anti-Drug Abuse Week. So it's a very therefore a very relevant topic. Another very important aspect about drug de-addiction is the point of stigma which is associated. So people don't come forward for treatment, and this stigma can only be relieved by educating the general public. So it's very important to increase awareness that patients who are drug addicts or who substance abusers should be treated as patients, as not as someone who is a responsible person, but they should be treated as a patient. And we know that, as I'm not a psychiatrist to advise the psychiatrists, and all of you know that de-addiction is not a behavior problem, but it's basically genetically ingrained. So there is always a confluence of genetic susceptibility and adverse environment influences, and it is only those people who have those genes ultimately become those drug addicts. So it's very important that we inculcate and increase these kind of facilities, and allow and encourage people to seek evidence-based treatment rather than going to clinics or going to places which are ill-equipped to treat these kind of disorders. It's very important. Follow up is also very important. Relapse rates and high rates of recidivism are the hallmarks when you start treating any patient who is an addict, because once off treatment doesn't work here, a rigorous evidence-based treatment, multidisciplinary approach and a multi-pronged approach involving all aspects and a prolonged follow-up is absolutely necessary to ensure that the patient does not go back to his old habits. So this is a long drawn process, and we have now a lot of evidence to how treatment has to be given. What is lacking is the implementation of that evidence by these strategies and increasing the treatment goals. So evidence-based, context-specific, resource-sensitive strategies needs to be evolved, and a policy needs to be in place, which is again evidence-based, to increase the number of treatment facilities who are drug addicts, so that we can give a good outcome and treat these patients who are drug addicts. They should not be treated as a irresponsible behavior, or individual blaming should not be done. It is the whole social environment, and an enabling environment is equally important when you rehabilitate the patients. I'm told there are a lot of integrated rehabilitation centers for addicts being set up by the government of India. Initially, it was set, I think, in AIIMS Delhi, PGH, and in Jipmer, and in Nimans, I think. But I think this should be, there are now about 320 integrated rehabilitation centers for drug addicts, and these have to be utilized properly by the people who need actually these kind of facilities and treatment facilities. Thank you again, Soyog, for organizing this wonderful workshop, and thank you for calling me to inaugurate as a chief guest. Thank you very much.
Thank you so much, sir, for enlightening the gathering with your talk. Now, I would like to request the chairpersons for our next session, that is session 2, to kindly come forward. I would request Professor Bhave and Dr. Rahul Tadke to chair the next session. Professor Bhave is professor and head of Department of Psychiatry at NKP Salve Institute of Medical Sciences, and he is the current president of Psychiatric Society West Zone. He is also the chairman of Cultural Subcommittee of Indian Psychiatric Society. He has been teaching for the past 37 years and has also been awarded the Lifetime Achievement Award by Bombay Psychiatric Society. He is winner of LP Shauration Award at IPS West Zone 2020, Nagpur Bhushan Award in 2003, and multiple other accolades. He has numerous papers in his name in multiple index journals, and he has authored several books and chapters. The Sir is also an acclaimed light music vocalist and has cut an album of his songs in 2010. Dr. Rahul Tadke is an associate professor at Department of Psychiatry, NKP Salve Institute of Medical Sciences, and he's the past president of Psychiatric Society of Nagpur and office bearer. He's also faculty and has multiple presentations at local, state, national, and international level of conferences and CMEs, and has various publications in multiple scientific journals. I would kindly request our chairpersons to now introduce our speaker, Dr. Malay Dave, who would be speaking on the topic protein kinase C inhibitors in addictive disorders.
Uh, Thank you, Bhavika. Dr. Malay, the way is fairly well known to us. I mean, you have been hearing his wonderful lectures, I mean, for many, many years in different parts of the country. And as all of you can see on the slide, he is affiliated, he is the honorary president of the Bombay Psychiatric Society, was in 2016-17, member of the IPS UG Education Committee 23-24, advisor to the IPS Biological Psychiatry Subcommittee. He continues to be an advisor to this committee. And his major achievements include 12 years as a PG teacher, 12 publications in index journals. He received the Bombay Psychiatric Society Silver Jubilee Prize in NSIPS Bhubaneswar, January 99, and Anil V. Shah Best Paper Award, 29th SIPS West Zonal Branch, Mumbai, in October 98. I mean, apart from this, he has got many more accolades to his credit. I mean, we all know he was conducting this wonderful clinic for autism at Nair Hospital and many more things of that nature. So it's great having you, Dr. Malay. Would you have any comments, Rahul? Okay. So over to Dr. Malay.
Good morning, everyone. And let me first take the opportunity to thank the Department of Psychiatry, AIIMs Nagpur, Dr. Suyog, Dr. Srilakshmi, and Psychiatric Society Nagpur for inviting me here to talk on uh, PKC, endoxifen, addictions, and the whole lot. And thank you all for being here on a Sunday morning to spend your time with us. After Dr. Ambedkar's lecture, it's difficult to match up to his very simplistic, very realistic, very practical, and you can just go out and implement whatever he has said. So thank you so much for that. I really enjoyed the talk. Now, from that very clinical, simple talk, uh, we'll get into some basic sciences which most people are not very happy to listen to. And, the first question they would ask is why? Why do we need to know basic sciences or anything about basic sciences? We are clinicians and we want something that we can, use in our patients right away. But what does happen is that whatever treatments we have are based on certain mechanisms that work in the body and the brain. And when somebody tells us about their symptoms, whether it be addiction or whether it be anything, any of the mood symptoms or cognitive symptoms or psychosis, and when we intervene on the basis of certain mechanisms on which the medications or the treatment modalities work. Any understanding of science, number one, is always in very, very small tumbling steps. There are no leaps and bounds. So in science, we are going to make lots of mistakes before we actually achieve something. So if there is a breakthrough advance in science every day, then well, that's not science, that's something else happening. Second thing is, the more we understand the basic nature of the difficulties or the diseases or the illnesses or the disorders that patients present to us, we would be in a better position to devise treatments that are effective, treatments that are specific, and treatments that have less side effects. And third thing, especially about psychiatry, is that most of our treatments are, or rather, most of our medications, so to say, and other biological treatments like ECTs, were all products of serendipity. Some things were discovered for some other purpose, but it was found that they work very well in psychiatric disorders and hence adapted. Whether it is chlorpromazine, whether it is lithium, whether it is this PKC inhibitors like endoxifen, they're all there for some other purposes. When a patient who had fever, schizophrenia, and had fever with chills, and he got better, then somebody thought that maybe a seizure is a treatment for something like this. Now, when we understand science better, we of course keep serendipity in mind. It's always a driving force, but we also are more well informed as to what is happening. And so I'll take this opportunity after this preamble to understand what the system of protein kinase C is and how does it relate to psychiatry, especially addictions, and so on. Now, protein kinase C is an enzyme system. So we call it PKC for short because it's so many words, takes time. Protein kinase C system is very well understood in mammals and very well understood, documented, researched, and some treatment modalities have been developed on that basis in human beings. And we have got a lot of data about the PKC system in the last 4 or 5 decades. So it's well known, it's nothing new. But the trick, or rather whatever is going to happen, is not because of PKC. Because if there is protein kinase C, there has to be protein kinase A, B, D, God knows how many more letters, alphabets, numbers. We know only one system very well. Now, what does it do? Rather, what it is. So, if we look at okay. Now, if we have this is basically a linear description of or a linear representation of what the molecule is. We are not going to get into any chemical structure. That will be very time consuming, not our cup of tea at all. But what is important is this, that if we draw a vertical line here, everything on the right is same and everything on the left is different. And that is how protein kinase C is not a single enzyme, but it is a group of similar structure enzyme with one half structure same and another half which is very different. Now, why it is important to know? Because clinically, the protein kinase system is of 3 classes. One is the typical conventional or classical PKC. Now, any enzyme system requires something to start, kickstart its working. So it requires calcium and diacylglycerol. Then we have novel PKCs, which require only diacylglycerol. And we have atypical PKC, which we don't know how it works, what kickstarts its working. And on the extreme right, we have isoform. So even PKC classical is not one type. Now, this reference is from a paper which was published in 2017. This is about 8 years now. Now, it is possible that in this 7-8 years, there would have been more isoforms or iso of isoforms that have been discovered. But roughly, even PKC is not one enzyme uniform. There are different isoforms. What does it do? Kinase enzymes are responsible for energy production, not production, but energizing certain molecules or de-energizing, means providing an energy molecule like ATP, catalyzing that reaction or removing that ATP. And it works on protein, so we are called as protein kinases. Now, a very simple diagram. This rectangle is the cell. So the boundary of the rectangle is the cell wall. The oval inside is the nucleus. So it has the DNA and all that. And the rectangular box is a protein. So what does energizing a protein do? A lot of things. What they've shown here is that on the cell membrane there is a protein, that orange colored box with P attached. Means under the influence of protein kinase C, this protein receives a phosphate molecule. So it gets the energy to do something. What to do? Either it will go inside the cell or it will remain on the cell. Now, this is what happens with the receptors that we know of. Any molecule that we use, its starting point is how it goes and attaches to a certain receptor. So we have all kinds of molecules: dopaminergic, serotonergic, noradrenergic, glutamatergic, and so on. And then we know that when we keep on continuously treating a patient for days, weeks, months, there is a change on the cellular surface regarding the number and sensitivity of receptors. So we call them upregulation or downregulation. When we keep on blocking a molecule, the number of receptors over time will go down, which is called as downregulation. And a down-regulated state for a long period of time will give cellular stability. So in hyperdopaminergic states, D2 blockers, dopaminergic down-regulation, patient remains free from psychosis. This is the logic. What we need to also understand is that our body, each and every cell of the body, works on the principle of economics. Means nothing is extravagant, nothing is useless, and every little bit of resource is used. So on a single cell, any cell in the body, neurons included, there are thousands and thousands of receptors of different kinds. So on a dopaminergic neuron, there will be n number of receptors of different kinds: serotonergic, glutamatergic, opioidergic, cannabinoidergic, whatever. But if there are 1,000 receptors on a single cell and there are billions of cells, to manage each and every cell with so many receptors is very energy consuming. So when receptors are not needed, they are okay, my work is done. The same protein kinase C will de-energize the receptor, and the receptor will come inside the cell in an inactive state. So receptors are not stable entities on the cell membrane. They can be on the cell, cell membrane, or go inside the cell when not in use. So that is one activity which is shown here, the transporter. Now, when we say patients have got better, actually what does it mean? Symptomatically, yes. Functional recovery, yes. But what is the medication doing? Exactly. Is the action the same as on day one, week one, month one year down the line, 5 years down the line? What is exactly happening? Now, when a cell has achieved stability, okay, now I am a cell and I am happy with 100 receptors on my cell membrane. 105, 10 tak theek hai, but I don't want 115. But I don't want 85 either. Now, to maintain this 100, the cell has to understand that something more basic has to change, and that is my DNA has to change in such a way that it produces so many molecules of receptors, proteins, and so many will be expressed. So unless and until long-term DNA changes there, things will not be, improvements will not be stable, recovery may not be stable. And so protein kinases act on all these levels. So if you look at the oval, DNA to transcription mRNA, mRNA goes out into the cytoplasm to protein. All these reactions, all these actions are modulated, catalyzed by protein kinase C. So protein kinase C has got lots of actions which are very basic from the cellular perspective, including how our drugs are going to behave. Right. This is actually a complicated diagram, but very simple. If we look at that red box, and I would just like you to remember amphetamine from that red box. Now, when we are studying all this kind of stuff, basic biosciences, we cannot study in a live human brain. So there are, and you cannot take out sections and also either it has to be post-mortem. Now, post-mortem is a different state from a living state. So we may not be 100% certain as to what is happening is actually happened. So there are animal models. We don't know if the mania in monkeys or rats is the same as mania or psychosis in human beings. Whether they have it in them, in their genes to produce a psychiatric state like that. But there might be something similar. Of course, they are not going to overtalk or overspend or become overtly religious or oversing and overdance, but there might be certain behavioral equivalents. And to produce a state like that in animals, amphetamine is one of the agents. Amphetamine models have been used to study psychosis. Amphetamine models have been used to study mood disorders, impulsivity, addiction, everything. So when there are these changes, you know, apart from amphetamine, there are those other things in that box. They are used as stimuli to produce a certain change. And this is a basic model of mania and many other things. But what is happening here is this is a hyperactive cell. Now they have shown a presynaptic and a postsynaptic neuron. So it's a overactive neuron, overactive neuronal activity in terms of increased PKC activity. Because as we mentioned in the previous slide, PKC is going to kind of catalyze most of the important things. So if a cell is working more, PKC activity is definitely more. It also is associated with increased neurotransmitter release of all kinds. And overall, synaptic activity is much more. So roughly what that enzyme system is, what it does at a cellular level, okay, what it does or what it is involved with in at a gross level or at systems level. So we have this PKC alpha. Why PKC alpha is because of all this PKC. PKC alpha is still more studied and has got direct applications in many of the disorders that our patients come to us with. So there are 6 boxes around PKC in the center. If you look at the lower 4, that is one part, and the top 2, which is another part. Right from conception, meaning that zygote is formed, single cell, then it starts multiplying. From that time, PKC activity starts. PKC activity modulates all processes right from day one of development. So we have number 1, cell proliferation. So 2 cell, 4 cells, 8, 16, and so on. This requires again a lot of activity. So one target is that. Second one is cell migration. So all the cells that are developing, they have to go to their future places. They cannot be in one spot. Third one is these cells have to come together and form connections. And finally, these connected cells have to specialize to form various subsystems. So the development of the nervous system in just 2 or 3 lines starts from as early as almost the second week, even less than that. Cells migrate along the central axis or notochord, go to where the brain is going to develop. So that's the migration. They'll keep on multiplying, they'll keep on moving. Then they'll reach their place and forms connections, which we call synapses. And then again, the whole brain is not uniform. There are different areas which are specialized for different things. So specializes. This is how the CNS forms till birth. But all these basic activities require PKC, alpha and other ones. That was a bottom half. The top 2. When systems are developed, Then the question comes is wear and tear, right? All cells die because they are used, or components of cells die because they are used. We want new. Now, this is a process which is balanced. What happens in our neurodegenerative disorders is more cellular damage, cellular component damage than regeneration. That's why we call them degenerative disorders. And what if there is excessive growth and less destruction? Then we call them cancers. So again, this maintenance of wear and tear, removal, how many new cells will come is all PKC. So broad actions. Now coming to what is of our interest. Our interest is PKC alpha, number one. Second, PKC alpha is a classical, so it requires both calcium and diacylglycerol. Third, the areas of importance are the prefrontal cortex, hippocampus, and amygdala. Now, between three regions, roughly, most of the disorders will have something to do or the other, especially addictions and impulse control problems. Okay. And what we have learned that over time, especially with our experience with molecules, immediate changes, short term would be neurotransmitter release, medium term would be upregulation or downregulation of receptors, and long term would be a genetic change, and how the system remodels itself, what we call as plasticity. So this is how we have summarized the activity of PKC as we understand. Mood disorders is again one area where this system is, well, at least the for us clinicians, the understanding of PKC is more or less parallel with the understanding of what happens with bipolar mood disorders. The first agent that was available to us for managing or maintenance of long-term bipolar disorder is lithium. The more we understood lithium, the more we understood what happens. It is actually the other way. First, the usual model is to understand a disease well and then understand what can be done for it. With lithium, it was the opposite. This thing. The more we understood lithium, we the more we also understood what happens in bipolar disorder, not only at symptom level, at a cellular level, and even at a genetic level. Whether there's an overlap between how patients handle lithium, means that genetics, and the genetics of bipolar disorder. Second molecule that we have understood, or rather we are trying to understand, is how a basic system like protein kinase C is involved in the pathophysiology of mood disorders. Now, when I talk of mood disorders here, it doesn't mean DSM-5 or ICD-10 mood disorders. It means a lot of things, those three areas that we talked about, the prefrontal cortex, the hippocampus, and the amygdala, how the working of these three is integrated to produce certain kind of symptoms. Bipolar disorder is not only depression and mania, but a lot of other things. Suicidal behavior, substance use. In mood disorders or in addiction, mood component, mood dysregulation, emotional dysregulation, emotional valuation becomes very important. And cognitive impairment. Cognitive impairment is not only memory, but the ability to concentrate, working memory are also cognitive tasks. Apart from PKC alpha, as I said, there are so many isoenzymes. PKC epsilon. Now, this is a small study. So, if it keeps on getting repeated similar results, well, this can become important, because if I am able to demonstrate that there is an abnormal expression of PKC epsilon in a patient right on day one, then this patient is prone to suicidal behavior and become a marker. Right now, the only prediction of suicidal behavior is a previous suicidal attempt. So we need to wait for the first to predict the second. Again, susceptibility, not only in terms of mood, but if you look at the last two lines in this, that cardiac function, insulin function, metabolic function are also integrated. Why? Because we are dealing with a system which is more central in producing a lot of things. Okay. Important ones from today's perspective. I mean, of course, mood is always there, mood symptoms are always there. Is how this can modify substance seeking behaviors like cocaine, like alcohol. So there are basic science studies. Now, substance use addiction is expressed as uh, the need to keep on taking a certain substance. Could be anything. We talked about opioids in the morning. It could be alcohol, nicotine, anything. And addiction can also be non-substance. There can be food addictions, there can be behavior addictions, there can be any number of addictions. So the importance is the process. That once this process is there, something or the other will keep on happening. And we need to manage the process so that the person is able to manage his or her life with minimal consequences. So, apart from the substance, there are a lot of other things that we need to pay attention to. One of them, and I will talk about this 3 or 4 slides about what is exactly happening. This basically is a representation of the default mode network, one of the most important networks that we understand. What does it deal with? What does it do? Well, it deals with the sensation, or rather the experience of self. I. Everything that I do has to get that label I. Me, my identity. Dealing with others. Who is there? What he or she must be thinking. And third and the most important one is integrating memories and experiences and attaching to all these things. Now, when I take some substance and I get a high, it is noted down as an experience with a value. Happens in all addictions, across the board, substance or otherwise. And it becomes a part of my identity. And default mode network also is important in not only self, others, and experience integration, but it is also going to predict future behaviors. One of the things that happens with our patients is where do you, where I, how do I think I'm going to get my next fix? What can I do? Where will I get the money from? Where will I prevent myself from getting too much into trouble? Prediction. It is prediction, it is not certainty, but predictions. So default mode network. Second one and the most important one is the salience network. Salience decides what is important for me. Alcohol, opiate, nicotine, caffeine, gambling, pornography, it decides. It is a kind of a setting. It has got values. Like this AC, we can turn on the temperature, we can turn down the temperature. But everybody is not comfortable at the same temperature. If I am comfortable at 24, it's my temperature. You may be more comfortable at 22, but then we don't have individual adjustments. So salience decides that what is important for me. This is a network which guides salience determined behaviors. Means alcohol, important to me, will be my addiction for life, and alcohol is at number 1. Coffee is at number 2. Water is at number 99. This is a setting. And once this kind of settings are in place, they do not change. And that is why the long-term management of addiction is also how we are going to manage the salience. And that is where, as sir mentioned, the OST comes in. You are substituting. Means we are not telling them, okay, now don't take alcohol, but drink water whenever you feel the urge. That doesn't work. That doesn't work because the salience is decided. Third important network is the central executive network. What is going to actually happen when I'm going to take up, when my default mode network decides a certain kind of prediction, my salience is this, what is my behavior going to be? That is a central executive network. So all our behaviors are an output of the central executive network. And what are these behaviors? They can be cognitive behaviors, the way I think. The way I think about alcohol. For some people, alcohol is related to, okay, I'll go to a conference whenever I go, friends are there, I'll take. That is my executive output, cognitive executive output. For some people, I need to take alcohol whenever I'm stressed. For some people, whether anybody comes or not, I'm going to have alcohol. So our central executive, he decides the output. What is the output? It can be cognitive in terms of thoughts. It can be in terms of emotional. If I don't get alcohol, I'm not very happy. I can't go to a dry party. And it is behavior. So central executive decides the output. Now, when we integrate all these things, we get a model of addiction like this. Simple, not complete by any means, because the more we understand, more things can keep on getting in. But what happens is three kinds of settings. One is the binge intoxication stage, rather, where I get the pleasure, where my salience is formed, fixed. Second one is withdrawal. If I don't get it over a period of time, I'm not happy. And the last one is preoccupation and anticipation, which is the craving. This is the cycle in which goes on. But if you look at the components are parts of everything: the default mode network, the salience network, and the central executive network. Now, when we understand a model like this, okay, well, each part is doing its function. So we have no argument with that. The problem is, if you look at the last bottom line, is the neuroadaptation, or what we call as plasticity. Now, this adaptation is long term. Plasticity is long term and by itself. But if there is a genetic component or an epigenetic component, it is lifelong. Because right from day one, the PKC is garbad, which is going to have an effect on development, which is going to have an effect. What in terms of development is all these networks that we are talking about, all the neurochemistry that we talked about is not okay. There might be minor differences, but the sum total of many minor differences is an illness. It is not something here or there. It's not a problem. There are a lot of other things that can take care of it. The homeostatic balance will be maintained. But many things in many networks is going to be lifelong adaptation change, or a lifelong maladaptive neuroplastic change. And that's why addiction behaviors have to be treated for a very long period of time. We have no idea how long. 20 years, sir mentioned. It could be more than that. Multiple addictions, we still cannot figure out what is going to be needed and how that person is going to be functional or recover over time. So we have to be prepared for the long haul. One was the networks. Second one which we come across is the impulsivity. Impulsivity is again cross-cutting. So it's not related to only one illness or only to addictions. It is present in a number of diagnosable conditions that we see. But what is this impulsivity exactly? Impulsivity is what comes out of an imbalance between inhibition and attention. For something that I need to do, I need to focus for as much time as it is needed. But at the same time, I have to inhibit certain things. So if I'm hungry now, okay, fine, after the lecture, so inhibit that. Okay, I'm getting a phone call, so I will not touch my phone. Inhibit. So work gets done, objective is attained, my prediction becomes more accurate if the balance between impulse control, rather inhibition and attention is good. Means attention wins over inhibition. I mean, both are good. The focus or the prime objective of human brain development is inhibition. Because right from day one, everybody keeps on telling us, don't do this, don't do that. Not good. ठीक नहीं है. Well, there is a moral value, there is a social value, and there's a developmental value. So the more we are able to inhibit, we are talking of healthy inhibitions, we will not, or we will be supposedly free from illnesses, addictions included, right? And then there are a lot of things which can go wrong, which we'll not get into, but we are just talking about inhibition, rather impulsivity. Now, when inhibition is not okay, attention is not okay, then whatever is an impulse, impulses are always there. Okay. If I'm not focused on it, I might not be able to process it, why it is happening, what is happening. And if the inhibition is not good, it will give it a free hand. So in addictions, this is what happens. When we tell them, uh, this is what we do in management of queue. Okay, when you are going to home from work, you pass a bar, okay, don't look at it, go. Now at that time, he should be able to focus on this thing and inhibit himself or herself from going there. If not, there is a chance of relapse. When we tell patients, you have to learn to say no. In a party, first of all, don't go. If you go, then you have to learn to say no. Because if you take one, actually your inhibition is down. The drug has a sedating effect. Alcohol has a sedating effect. So all the cognition will go down. So when people relapse, especially with alcohol, and as sir mentioned, when they retake something, they usually take in a very high dose. So that whole alcohol history will be 15 years, but in relapse within a month or two, again, it's back to the same or maybe more. Right? This is the basis of that. So as I mentioned, cross-cutting. I mean, inattention, impulsivity is cross-cutting. It is not only limited to ADHD. Each and every disorder will have a component of inattention, more or less. Okay, so this is a study which shows different kinds. Now, what we are interested again, where does it come from? Now, impulsivity is not one kind. Okay, there are different kinds, two main kinds. One is stopping and one is waiting. If I start something, then I need to learn to know that if there are enough signals, I have to stop whatever I am doing. That is stopping impulsivity. And another one is waiting impulsivity, means I'm not doing anything. I'm not supposed to do anything, but then something will happen. So two main varieties of impulsivity from the brain perspective, not on scales, brain perspective, how the brain functions. If I keep drinking, I'll not know when to stop, especially binging. Okay, so that's the stopping impulsivity. Waiting impulsivity. Okay, you need to be patient. If you get the impulse, just calm down. No. Now, both this kind of impulsivities have got different brain substrates. The stopping impulsivity is more dorsal, means more above, including the cortex, and the waiting is more at midbrain level. The circuits will overlap, the neurotransmitters will overlap, but the functionality is different, right? If we project those dorsal striatum and ventral striatum, then again, different impulsive behaviors have got different substrates. This we are able to understand better now when we have better imaging tools like fMRIs, DTI. Okay. Now we are able to correlate. Means we talked of big networks, default mode network. We talked of salience network, we talked of central executive, but this becomes a specific network. Specific even in the reward network, because there is a certain kind of impulsive behavior which is guided by a certain kind of connectivity. How is this important? If we can develop a modality which can modulate this circuitry, we can have better options. Yeah. Now coming to what we have available now, which can modulate protein kinase systems. Why we went through this whole thing is when we have abnormal development, when we have got abnormal working systems, in each of them, we have found out, or it was found out, that the PKC system is overworking and it needs to be calmed down a bit. Okay. The first ideas came from tamoxifen. Tamoxifen used for estrogen sensitive breast cancers. Again, endoxifen is serendipity. Women on long term use of tamoxifen would start feeling depressed. The commonest thing that will happen, observation that anybody will say, "Arey, isko cancer is इसलिए depressed है."
Dr. Bale, sorry, 5 minutes more.
Yeah. So it is not that. The pathophysiology again can be common. Cancers, depression, there is an overlap. Secondly, we have an agent which can actually cause depression. And that is where people thought, okay, let's try it for mania. But then it has its own side effects. So the end product of tamoxifen metabolism was developed. The idea was different. The idea was whether endoxifen is a better chemotherapeutic agent for cancers. But they found that it had almost none of the side effects of tamoxifen except very few. It's an end product, so it doesn't undergo further metabolism. It's a very predictable molecule. No second pass, first pass, this can happen, that can happen. Very safe that way. But what happened was that in its form like this, the anti-cancer effect, which was some specific estrogen receptor modulation, that part was minimal. The protein kinase, anti-protein kinase activity, protein kinase C activity was much better. And so it was studied for mood disorders. Simple molecule, linear profile, but long half-life, so once daily dosing is enough. No drug interaction, nothing to worry about because it doesn't get metabolized. Now, for substance use, and we go back to that orange box in that diagram where amphetamine was mentioned. So, tamoxifen and amphetamine abuse. Once people found out that tamoxifen has got certain, let's say, psychiatric properties, when this model was used, okay, this is I think a 2017 paper, not again, even before the first therapeutic, I mean, first paper on endoxifen for bipolar disorder was published, this was published. And they found out that in rats, this amphetamine seeking, taking behavior reduces. So that was the first evidence. There was certain evidence before that. But what was that evidence? Protein kinase overactivity impairs prefrontal cortical regulation of working memory. If working memory is poor, overall functioning and functional recovery is bad. Working memory impairment, if you take any chronic disorder like schizophrenia, there is a working memory impairment which doesn't improve over time. So this is 2004, I think. This is 2004 paper. First indication that there can be a cognitive problem if there is PKC overactivity. Once we have molecule, the molecule has been approved by Drug Controlling Authority of India for bipolar disorders, is in process for FDA approval now. The multi-centered US studies are done, so whatever comes out of that. So we have been using. One way of understanding what a molecule works is we use it we see, because in clinics only bipolar patients don't come. They'll usually come with a lot of other things, impulsive behaviors, especially if you're looking at very fast, rapidly cycling disorders or borderline kind of patients, where again there are mood symptoms. They come with a lot of things. So when we use it for more patients, we get certain experience. We can share that. To make it more systematic, we need to have case reports reviews, which works as a narrative kind of review, because these are not controlled studies, but they will add to the base. Once we have enough, then the time will come to have proper randomized controlled trials. Till then, what has happened? So this, all these papers are freely available. I'm just giving just a snapshot. Endoxifen in substance use and bipolar. So we started using it for bipolar with substance. One more addition. Alcohol dependence. This is a series. That was a single case. This is a series of, I think, 3 or 4 patients. Again, the same thing. This patient I had contributed to this paper, but my patient was bipolar with cannabis use. Cannabis, actually, it was cannabis induced psychosis with a lot of mood swings. Patient admitted, ECTs were given, still there was partial recovery and active cannabis seeking and craving. Then we have this case series, 5 patients, borderline presentations. Why I gave this here is because there are a lot of things happening here. Mood fluctuations, impulsive behaviors, substance use. As I said, not only limited to substance, behaviors. Right? People who take risks in investing. All investment is not sane investment. It can be a problematic investment if we have not thought, even if you have thought through in today's times, anything can go for a toss. But then
Sorry,
let
sir,
us be,
but we are a
yeah,
bit over time.
just once, the last one. So addictions like this, okay, again, alcohol. So that was what I thought I've understood about protein kinase C. Its involvement in many kinds of presentations, and what we can do now that we have something available that can modulate the system. Thank you so much.
Thank you, sir. Thank you for the excellent and in-depth presentation and making us realizing the importance of the molecules and molecular level. The questions from the participants.
Thank you, sir, for excellent presentation or taking us to our biochemistry first MBBS level. Uh, what I understood, protein kinase C requiring diacylglycerol, calcium, transcription, translation, and then proteins. And this is happening in every cell, every dividing cell, that cell proliferation, differentiation, apoptosis, tumorigenicity. So, considering our topic of addiction, where we require to continue this medication for a longer time. So, how can we continue this for a longer duration? Because it will affect other cells also in the body which are dividing.
Yeah.
And for a long time, this protein kinase C will be inhibited in those cells also, which are not directly related to our mood regulation or impulsivity.
Yes. So protein kinase C, yes. But as I said, no, there's not only protein kinase C. There are other systems also. So what happens is this, that when we have one system which is inhibited or working more, there are other subsystems which will try and maintain the homeostasis. That's one. Second thing is, um, when we give this, we have to see where is the concentration of the drug reaching maximum and how susceptible other cells are. Okay. So what happens is, see, any molecule that you give, even if you give haloperidol, for example, or rather, let's say we give an SSRI, for example. In fact, the concentration of serotonergic receptors is more in the GIT rather than the brain. But apart from that initial GI symptoms in many patients, which settles by itself, there are only very few who have very severe side effects and need discontinuation. So that we should wonder why that is happening, because the concentration, the presence of all kinds of serotonergic receptors is much more in the GI than in the brain. Similarly, other receptors are also there across the body, but when we give a molecule, nothing seems to happen elsewhere. So the point is, where is the drug reaching its maximum concentration? So this is what is happening. Second is our observations. Now, when we talk about theory, as I said, we are talking of PKC alpha. This is the drug is based on that. Now, whether that is enough, when I talked about all that, uh, the other things, it is the whole system of PKC, including PKC alpha, that is working. What happens over time is all the systems do not work in the same fashion as in day one or day 100 of or year 100 of our lives. It depends what kind of activity is needed. Even at cellular levels, all cells don't have the same activity. So we do not want this kind of activity happening. So genetically they're turned down. Sum total is that when we are giving it for years together also, now we have it available since about 3 years or 4 years. There are peop- there are patients who probably would have received for more than a year and a half with no side effects. The question then comes is whether it has got that SERM activity like tamoxifen. Now, when we give endoxifen for SERM activity, in most of the patients for whom we are giving it for SERM will require doses upwards of 120, 140, 160 milligrams per day. So there will be some women who will have some menstrual issues when you after starting this, but there'll be very few, and probably they are sensitive to this kind of change. Most of the time, even when you continue for a long period of time, it doesn't get affected, right? So we are looking at one system, we are looking at how we can modulate it. There is going to be an influence of other isoenzymes, other PK systems, protein kinases, and other kinases. So it's not one system. This is what our basic understanding tells us. Clinical experience is also similar. So long-term no effect on metabolism, long-term no effect or hardly any effect on endocrine functioning or immune functioning. This is what we know.
Right. Any more questions? I think we can have two questions. Yeah. Yeah.
Um, Good morning, sir. So, sir, I wanted to ask on starting endoxifen for addiction treatment. So, we should start in those patients in which we suspect such mood regulation and long-term treatment, or in plain addiction also for short-term, like 6 months, as an anti-craving agent.
See, from what people have tried, what I have tried is we will always start with our regular treatments as usual for any kind of addiction. Okay. Uh, why would we select something like this? Now, if you ask me, if you compare naltrexone with endoxifen on that anti-craving or anti-impulsivity, this is slightly lesser. Where would I start it? Clinically, addiction, whatever it is, as I said, not only substance, but others also. If there is a strong mood component, that is one. Secondly, uh, for most of the patient, it will not be the single molecule. So I'm not going to start uh, on day one and just keep that one molecule. it looks like this, it works, but again, it will work differently in different people like any other molecule. Second thing is the side effect burden is very less, right? So if in your patient you have got a lot of impulsive behaviors, you have got mood dysregulation, if you are looking at cognitive impairment, then this would be a good addition. Now, whether you're going to maintain that patient long term on this will be a long term decision. So if he or she is remaining stable and you would, we discussed when would you like to reduce or taper down. When it comes to that, well, you may keep it on, reduce the others and see what is happening. So that patient of mine where I had used it for cannabis plus mood, his final maintenance dose, he was a 25-year-old male, now working well, but unfortunately lost to follow-up. But stable on what dose? 5 milligrams olanzapine, 8 milligrams of endoxifen, and some zero point 0.5 clonazepam, 3 medication. Whereas without that, he had received the heaviest doses, about 30 milligrams of haloperidol, 1500 of divalproate, plus olanzapine, plus some 2 or 4, 2 milligrams of lorazepam, still ups and downs, still craving going on. So compared to that, this is hardly anything. Now I'm waiting for him to come back. He'll probably have a relapse because that pattern is there. Substance use is addiction is there. Mood dysregulation is there. If he's really, really fortunate, good genetics, non-contributory family history, which I don't remember now, he may not have a relapse. Good purpose is served.
Sir, and maximum till 8 mg or in 16 mg also.
So, well, if you are looking at severe behavior problems like mania, it is better to start with 16 for the first week, then go to 8. Severe behavior problems. Otherwise, 8 is start, maintain.
Thank you so much, sir.
Any last question? Okay. So if there is none, thanks a lot, Dr. Malay. I think you did break down some very complex concepts in through very simple language, use of few words, but a lot of clarity. So thanks for the wonderful talk. Thank you so much. Over to the MOCs.
Thank you, sir. I would now like to request our chairpersons to kindly felicitate Dr. Malay Dave, sir. Thank you, sir. I would request Dr. Srilakshmi to kindly felicitate our chairpersons, Professor Sudhir Bhave, sir, and Dr. Rahul Tadke, sir. Thank you, ma'am. Now we would proceed for a very short tea break. I would request everyone to kindly resume very soon, as we would be starting the next session after a few minutes.
Welcome back, everyone. We will now begin our third session on setting up a private de-addiction center by Dr. Suresh Patil. Setting up a private de-addiction center is both a clinical and logistical challenge. In this session, our expert speaker will walk us through the key elements of turning that vision into a reality. This session will be chaired by Dr. Vikas Bhute and Dr. Nikhil Pandey. Dr. Vikas Bhute has been practicing for last 28 years and has 28 years of clinical and leadership experience. He's a founder and owner of Treat Me Hospital in Nagpur. He runs an inpatient and outpatient psychiatric service with a focus on long-term recovery, supervises a team of mental health professionals and ensures quality standards, implements protocols for de-addiction, dementia care, and management of psychotic disorders, conducts individual consultations, family therapy, and treatment planning for chronic psychiatric cases. His specializations include indoor psychiatry, de-addiction and rehabilitation and dementia care, and schizophrenia management, as well as community mental health awareness. Our second chair is Dr. Nikhil Pandey. He's a practicing psychiatrist since last 18 years, director at Mano Vikas Clinic in Ramdespet, and a director at Asan Hospital in Dhantoli. He has been the ex-president of the Psychiatric Society of Nagpur and ex-honorable secretary of Vidarbh Psychiatric Society and Psychiatric Society of Nagpur. Kindly invite them on the stage. And I would like to invite the chairpersons to introduce the speaker, Dr. Suresh Patil.
Hello. It's my pleasure to introduce our friend Suresh Patil. Suresh did his MBBS from Government Medical College, Solapur, DPM from Nair. He's a university topper in psychiatry from prestigious Nair Hospital, leading psychiatrist and sexology expert in Vasai Virar since 2011, founder of three Shanti clinics offering holistic mental health care, founder of a Vibhas Psychiatry Hospital, Palghar. He's a founder of a Vishakha Psychiatric Hospital. He's launched Yashwant Wellness Center, a 150-bed facility for rehabilitation and dementia care. He's a president of Nala Sopara Medical Association, conduct mental health awareness camps and professional training. Apart from this introduction, Suresh is known to us because many times we read a very good forward, Marathi forwards written very nicely, amusingly about our patients. And they are from the Suresh Patil from Vasai, Virar, Nala Sopara, Navi Mumbai. He's the same guy. Uh, I was always wondered की इतकं छान मराठी असं कोण लिहितं म्हणून म्हणजे सायकॅट्रिस्ट आहे डॉक्टर आहे सी मराठी बोलणं आणि मराठी तसं लिहिणं म्हणजे लेखी मराठी वेगळी असते ते एवढं छान लिहिणारं कोण आहे म्हणून तर हा सुरेश So Suresh, I know since last 5-6 years, but this is the first time we are meeting, and we are going to listen on very interesting topic about rehabilitation because he's already running 3 hospitals in the same 5 kilometer radius in Mumbai very successfully. So it will be very enlightening, going to be a very enlightening session for all of us. Over to Suresh.
Good morning, namaskar, namaste. Today I'm here to share my experience on setting up private de-addiction center. Dr. Ambekar sir played inning like Sachin Tendulkar. Dr. Malay Dave sir played like Dravid. I am a backbencher and tailender since my throughout life, from college life, school life, now in the psychiatry also. I never know why Suyog choose me. I come to that point later. Addiction is not choice, but recovery is. कोई जन्म से पैदा होके नहीं आता है कि मैं मस्त मजा करूंगा लाइफ जीऊंगा और एडिक्ट बन के ही जीऊंगा एडिक्शन इज अ डिसीज एंड रिकवरी is a choice. But that choice we need helping hands, some kind of help in the form of counseling or we call it the de-addictions centers or therapies. Disclaimers. These are very important. आज मैं जो बोलूँगा वो कोई इंटरनेशनल, नेशनल, नागपुरन, नाला सुपरन गाइडलाइंस नहीं है. These are my live experiences. जिसको जो जमे वो ले लो, जिसको जो नहीं जमे वो यहाँ ही छोड़ के चले जाओ. नेक्स्ट, माय फर्स्ट क्वेश्चन टू मी, मुझे क्यों बुलाया? आई एम हिज कलीग, आई नेवर मीट हिम इन कॉन्फ्रेंसेस, उसके लिए मुझे बुलाया होगा. फर्स्ट थिंग, उसका कलीग तो नहीं लगता, वो मेरे सेंग लगता है, मेरे बाद गए हैं, लेकिन मैं उसका बैचमेट हूँ. सेकेंड थिंग कम इन टू माई माइंड, मे बी आई एम अ साइकेट्रिस्ट विद यंग माइंड, विद एटीट्यूड, जिंदगी में कुछ बड़ा करना है. थर्ड, व्हाट ही टेल मी दैट यू आर जोनाल्टा, किधर भी चलता है. मूड डिसऑर्डर है दे दो, सब्सटेंस है दे दो, एडीएचडी है दे दो, ओसीडी है दे दो. So later in the sincere term, you tell me that you are the psychiatrist who have running the 3 setup, acute care in psychiatry, a male de-addiction center, especially female de-addiction center. So I come to that point later on. Second disclaimer, अभी सब जगह महाराष्ट्र में महाराष्ट्रात चालू आहे, हिंदी ही पहिली भाषा पहिलीपासून शिकवावी का, तिसरी भाषा पहिलीपासून शिकवावी का. So my English started when I completed my MBBS and joined psychiatry. My Hindi started when I started practicing in Nala Supara, Bhojpuri kind of Hindi. Marathi I learned from the day one, because of that I'm very good Marathi writer. अगर मैं बचपन से इंग्लिश लिखता तो इंग्लिश भी अच्छा लिखता था. So triphasic attitude for the today's lecture, Hindi, Marathi, English. We call it as English. Practical tips, not a theoretical guidelines. So these are the practical experiences, not a theoretical guidelines. Don't ask any question to me about receptors. I left receptor 15 years back after my PG. Thank God Malay Dave sir is here, so I'm not worried कि कोई भी क्वेश्चन रहेगा तो मैं इनको फॉरवर्ड कर दूंगा. Why this talk? बहुत स्कोप है इसके लिए टॉक है. Growing addiction crisis in India. Lot of patients who require treatment but don't have facilities. When you अगर सपोज लायन शिकार करता है तो लायन ने शिकार करके लायन का खाना चाहिए. लायन ने शिकार किया और नहीं खाया तो हाइना खा जाते हैं. Many of my colleagues always complain, अरे इतने रिहा ये लोग चला रहे हैं, कोई भी चला रहा है. अरे आप नहीं चला रहे उसके लिए वो चला रहे हैं. So is to change the attitude, this kind of talks are very important. We have very limited quality rehabs in India. I am mentioning the special word quality rehabs in India. A psychiatrist led holistic approach is needed in the field of de-addiction. And this is an inspiration for all the young minds कि कोई भी साइकेट्रिस्ट अगर थोड़ा टाइम निकाले, थोड़ी इच्छा पैदा करे तो दी एडिक्शन सेंटर चला सकता है. इट्स नॉट डिफिकल्ट. एवरीथिंग स्टार्टेड फ्रॉम हियर. आई टुक एडमिशन इन नायर. माय एचओडी asked me, भैया why you took psychiatry? My HOD always asks everyone why you took psychiatry. I'm very confused कि why you psychiatry. सब लोग बोलते थे कि want to serve people, I like the branch, I want to explore the mind. I was सीधा साधा बच्चा. I told directly, I want name, fame and पैसा. सब लोग हंसने लगे. Name, fame is okay. Where is the पैसा? So then 2 साल 2.5 साल ऐसे ही निकल गए. When I passed my final exam, भाई बराबर बोलते थे क्या करने का है, what to do. I started a private practice in originally I'm from Kolhapur, but Sasural is very important thing in life. So I settled in Vasai Virar. So Vasai Virar, I started OPD. I realized I'm earning penny, but I started my journey to de-addiction center, visiting a psychiatrist as 2 de-addiction centers. One thing I want to share or uh, learn myself that in medical colleges, most of us taught medical science, not art and commerce. In medical institute and colleges, every teacher need to teach a student art in the psychiatry and commerce in the psychiatry. How to develop art so you become a good psychiatrist, and how to earn the money, how to manage the business, how to convert the science into the finances. So my journey as a de-addiction psychiatrist is very funny journey. It's on bike, not on car. Every Sunday, I used to. My Vasai Virar area is a hub for de-addiction centers. From the Ahmedabad to Mumbai highway, there are 20 rehabs which is run by non-medicos. So every Sunday I used to visit there. For per visit, they give me 2,000 rupees. So at the end of the day, I get a 15 or 20,000 rupees. For every Sunday, my income is more than my whole income in the month in the OPD. So I observe who is running the de-addiction center. Recovery addicts, so-called recovery addicts. They are addicts, but they tell themselves they are the recovery addicts. Some institutes, spiritual institutes, Seva Wala institutes, they are all making business on the name of Seva. I saw they lack dignity, second, scientific care, and last is empathy. What is the turning point in my life? 5 years I built my OPD. Over the time, my OPD running very well, but still I am continue to visit the rehab centers. This was a trend, but one day changed my life. One young male admitted with cannabis dependence with psychosis. He locked in the rehab center for months without medicine, and suddenly he died. I'm not aware. I'm not informed. I read that news in newspaper. I was helpless, hopeless as a consultant psychiatrist. This incident motivated me to start something new. So in 2018, along with two psychiatric colleagues, Dr. Devendra Save and Dr. Kirti Tandel, I started a Vibhas Psychiatric Hospital, Vasai Virar Institute of Behavioral and Human Sciences. This basically for acute psychiatric care with some patient of addiction, specifically for detoxification, not for the rehab. This was a 42-bed multidisciplinary team. We did excellent well in acute psychiatry from the ECT, acute patient management. We are doing since last 7 years. What problem I found in a Vibhas that the most of the Mumbai's hub for addiction, especially a female patient addiction is increasing in Mumbai. The trend is too much on the name of equality, or I don't know, but the cannabis, opioids, and all the drugs are running havoc. So the first time I think that we did something new. So we started a first de-addiction center for female. And along with the de-addiction center, we'll take a license of female psychiatric hospital also. This was a 25-bedded small setup running successfully. Now I plan to expand that setup because over the time, last 2 years, I found it should be more than 100 beds because very few centers in India that serving a female with de-addiction, female for de-addiction. Now the last thing I observe in both Vibhas and Vishaka, ki detox is not everything. De-addiction program and de-addiction centers is one thing that transform the addict's life. So lastly, I started 150-bedded de-addiction center for the male patients. Where I can give a structured program, yoga, CBT, group therapy, where I can implement the principles of addiction psychiatry. This is my center. The center is located 5 kilometers away from city in a village where 2-acre land is there. Why I started the addiction center? First thing is the need of power. Second is the rising of youth addictions. Limited scientific centers and scientific data available. And lastly, a psychiatrist center, psychiatric lead, holistic treatment we can plan. So now I will share to all my colleagues and young psychiatrists how to start, how to run, and how to develop. The first thing is where to start. Choose place wisely. Keep place away from the city. Every family love nature. So try to find out the centers who are in the nature, specifically in the villages, outskirts. Outside area should be calm, green, and away from all daily routines. So ideal spots are the old resorts which are not running, old hotels which are not running anymore. The center should be accessible to families. ट्रैवल कंपोनेंट इज वेरी इंपॉर्टेंट. बेसिकली मैं कभी भी जब भी क्लिनिक चालू किया तब मैंने यही सोचा है कि एक रिक्शा पे पेशेंट पहुंचना चाहिए क्लिनिक पे. सो सेम टर्म आई यूज हियर कि 2 रिक्शा 3 रिक्शा नहीं बदल लेना चाहिए. एक कोई भी एक व्हीकल से वहां तक पहुंचना चाहिए. थर्ड इज द प्लेस शुड बी दैट सो दैट लोकल लाइसेंसिंग नेवर बी इशू. ओसी नहीं है, सीसी नहीं है, बिल्डिंग की प्रॉब्लम है, ग्राम पंचायत दाखला नहीं दे रहा है, दिस काइंड ऑफ ट्रबल नहीं चाहिए. हाउ टू स्टार्ट? Build a team. It's not difficult to build a team. You cannot go everywhere. I'm running a 3 OPDs and managing 3 centers, not running a 3 centers or doing all things. We need a team of psychiatrists, good psychologists, good admin is very important. Then social workers, addiction counselors, nursing staff. Most important is a good cook. And last is the security guards. So this team is very important. Step 2, licensing. Mental health licensing is not that much difficult now. ठीक है, मेरे दोनों हॉस्पिटल को आई गॉट अ मेंटल हेल्थ और परमानेंट का लाइसेंस. द नॉर्म्स आर वेरी इजी. ठीक है, वी हैव टू fulfill the same norms that we are doing to Bombay Psychiatric Nursing. Then they easily give. Even without you're not fulfilling the Bombay Nursing Home Act norms, still they do audit and they give us certificates. They never trouble a psychiatrist. If your center is run by psychiatrist, our authority always help us because they want it. Third is most importantly infra. A good infra can only bring a good clients. So this is about infra. These are my wards in Vichaka. See the color combination. The color combination should be females को क्या अच्छा लगता है, साड़ी के कितने कलर है, ये कलर कैसा है. They like colors. So choose color interior very wisely so that उनको उधर रहना है. This not hotel stay कि आज stay करके चला गया. They used to stay there for 1 month, 2 month, 3 months. तो उनको ऐसा लगना चाहिए कि ambience अच्छा है. Cleanliness. These are the male ward in my rehab center, de-addiction center. Cleanliness is very important. स्टाफ को इंक्रीमेंट एवरी 6 महीने में थोड़ा थोड़ा इंक्रीमेंट करने का. साल में भरमसाठ इंक्रीमेंट एक टाइम नहीं करने का. 6 महीने में 3 महीने करने का. 2 टाइम स्पेसिफिकली यू हैव टू मेक अ गुड रिलेशनशिप विद स्वीपर्स एंड द सिक्योरिटी गार्ड्स. वो सबसे यूजफुल पर्सन है. थर्ड थिंग इज अ काउंसलिंग रूम. The best important thing is that as a psychiatrist, you have to spend a true time, at least a few minutes in the rehabs. I find that many times now psychiatrists don't talk with the patients only. If you're admitting patients, it's your responsibility at least to spend few time with him. Whenever you visit now, talk with each and every patient. These are the therapy hall. What family get more attracted to this kind of therapies? Like if you're starting a yoga in your center now, the family get attracted. And yoga is definitely beneficial. I don't have research data and all, but I think it is very peaceful to when patient do regular yoga. Kitchen. Pet first to man must. So kitchen is a very important thing in the rehab center hospitals. Why? Because after discharge now your family patient complain about 2 things. वहाँ का खाना अच्छा नहीं था. और सेकेंड थिंग कि पेशेंट का कंप्लेंट रहता है कि वहाँ का साफ सुथरा नहीं था. सो किचन इज वेरी इंपॉर्टेंट. दोज हु आर रनिंग हॉस्पिटल्स एंड सेंटर्स ना हफ्ते में एक बार खुद खाना खाने का अपने हॉस्पिटल्स में, तो स्टाफ को पता चलता है सर कभी भी खाना खाएंगे, आज डांटने वाले हैं. सेकेंड थिंग, क्रिएट अ मेनू. रोज अगर एक ही खाना दोगे तो पेशेंट बोर हो जाते हैं. 7 days के 7 अलग अलग सब्जियां बनाने का. ठीक है, हफ्ते में 2 बार फिश रखने का. ये चीजें बहुत पेशेंट को खुश करती है. बिकॉज उधर करने के लिए क्या है, उनको खाली लेक्चर्स है, रिक्रिएशनल एक्टिविटीज है, लेकिन फूड इज वेरी इंपॉर्टेंट थिंग. 4 बार अगर अच्छा खाना मिलेगा, ही इज बी हैप्पी. इवन आफ्टर रिलैप्स विल कम कि खाना अच्छा है. या स्पोर्ट्स. स्पोर्ट इज माय पैशन. आई वाज यूज्ड टू प्ले football in school time, a good football player. So I try to use that hobby as a activity and one of the recovery path for the addicts. I started indoor table tennis, carom, chess, outdoor volleyball, cricket, so that they can enjoy. सब क्रिकेट सबको पसंद है. Every addict, every patient, every person, even our staff too used to play with them. They are happy. Good bonding when they play together. Recreational activity. गाना बिना मुझे नहीं आता है, लेकिन आई एम गुड listener. So Friday night we enjoy a coffee night. एवरी डे मैंने कुछ ना कुछ दिन बनाया है, तो फ्राइडे नाइट और कॉफी नाइट तो सब लोग गाना गाते डांस करते हैं, भजन चलता है, तबला चलता है. एडिक्ट्स आर द क्रिएटिव पर्सन्स. और कोई कोई बैच में एक तो मिलता है which has a mood symptoms with the addiction. So वो माहौल बन जाता है. Second thing is that's my hobby, writing and reading. So I started अक्षर दालन. कोई भी समारंभ वेयर आई गो ना, मैं सबको बोलता हूँ आई डोंट नीड अ बुके, गिव मी बुक. दैट थोड़ा स्वार्थीनेस है. आई नेवर वांट दैट. वो जो ट्रॉफी वगैरह देते हैं ना, बाद में रख भी नहीं पाते. बाद में वाइफ चिल्लाती है कितना लेके आएगा. So book is one thing that is very important. So I started अक्षर दालन. Some exciting activities. So family को बहुत अट्रैक्ट करती है. I started सोना, स्ट्रीम बात एंड ऑल. ये देख के मेरे एरिया के डॉक्टर ही बोला, अरे शायद हमको एडिक्शन करना पड़ेगा, तेरे पास आना पड़ेगा रहने के लिए. इट्स लाइक होटल. लास्ट इज अ स्विमिंग पूल. So this kind of new, if your area, if your जगह, then you can do it. Last safety measures. सबसे इंपॉर्टेंट चीज साइकेट्री और अदर हॉस्पिटल्स में है कि पेशेंट्स आर, रिलेटिव्स आर नॉट स्टेइंग विद द पेशेंट. सो पेशेंट इज अ टोटल योर रिस्पॉन्सिबिलिटी. कोई भाग गया तो भी फैमिली उनको ब्लेम करती है, तुमको अगर संभालने नहीं आता तो क्यों लिया था. So for that required CCTVs, alarm system, bedside alarm, multiple key and lock systems, and two different exit and entry points, and last one is bouncer. एक तो वार्ड बॉय ऐसा चाहिए कि उसको देख के ही थोड़ा डरे, जैसे अपने नायर हॉस्पिटल और साइन हॉस्पिटल में एक आधा दूसरा वार्ड बॉय रहता था. दिस काइंड ऑफ सिस्टम इज देयर. व्हाट अदर रिहैब डोंट हैव, that is ICU setup. Most of the rehabs now in the periphery send patient to me, specific for detox. They don't manage opioid withdrawal. They don't manage complicated alcohol withdrawal. So they refer to me patients, sir detox करो और मुझे भेज दो, हमको भेज दो. I am happy with them. Either we are helping to each other or they are going in the good path. So this is one thing that make me different from the other rehabs. Detox with ICU beds. Ambulance and pickup is very important. If you have own ambulance system ना, तुम किसी को भी कहाँ से भी उठा के लेके आ सकते हो. When you are picking up patients now, always give a prescription with them. मैंने एक बार पिकअप के लिए पेशेंट को लेने के लिए भेजा, वो पेशेंट ने सोसाइटी का आलम लगा, पूरी सोसाइटी वो हमारे एम्बुलेंस के पीछे लगी थी. बाद में एक इस पे पुलिस ने पकड़ा, बोला कि तुम उसका अपहरण कर रहे हो. तो मेरे जो पिकअप वाले थे वो जेल में थे, मुझे कॉल आया, सर हमको पकड़ा इसके किडनैपिंग के केस में. सो फिर मैंने वहां से चालू किया, जिसको भी करना है उसके फैमिली को मैं पहले बोलता हूँ, प्रिस्क्रिप्शन लिख के देता हूँ, उसको एडमिट करना है. सो कहीं मेरा जो पिकअप वाला है वो जेल ना जाए. बिकॉज एवरी टाइम यू नॉट यूज एम्बुलेंस, मेनी टाइम वी यूज बाउंसर्स. वो जाते हैं, बोलते हैं कि हम पुलिस है, तुम्हारा इंक्वायरी या पुलिस स्टेशन जाना है, उठा के लेके रियाब में लेके आते हैं. पेशेंट प्रोफाइल बेसिस. सर अंबेकर सर, ओपियोइड इज इन स्टिल पीक इन मुंबई. मेरा एरिया इज हब फॉर एडिक्शन पेडलर्स. अभी लास्ट 2 months अराउंड 200 करोड़ का ड्रग्स मिला इन मीरा रोड नाला सुपारा एरिया में. So young cannabis, alcohol dependence with the ALDs, opioid dependence, elderly benzodiazepines, substance into psychosis, and medically completed substance dependence. These are the patients currently I am seeing in my rehab. Real case example, the 35-year-old engineer, opioid dependence, admitted with the in aggressive state. 3 months later, detox, rehab completed. He work as a volunteer in our rehab. I always give option. जाने से पहले थोड़ा काम करना चाहता है क्या? If it is cognitively good, if they work, I take them as a volunteer. Then after whole treatment, now he started working back. So he didn't just quit the drugs. He rebuilt his life. Financial aspect. पैसा कहाँ से लाने का? This is a myth कि बहुत पैसा लगता है. We need a team. So my first advice कि don't buy that land or don't buy that property directly. Take on the rent. Make a LLP. Come together. Make a institute and start running it. Over the 6 month, 1 month में समझता है कि every 6 month, 1 year we have to do a partner audits, mental health audits. पार्टनर का मेंटल हेल्थ बराबर चल रहा है क्या? देन डू फाइनेंशियल ऑडिट. क्योंकि सबसे बड़े गफले पार्टनर्स में होते हैं. सेकंड इज कैलकुलेट द मंथली बजट. व्हाट आर द टोटल एक्सपेंसेस, कितना आएगा, प्रॉफिट कितना हो रहा है, कहाँ हम एक्सपेंसेस बढ़ा सकते हैं, कहाँ खर्च कर सकते हैं. स्टाफ सैलरीज, गुड सैलरी टू स्टाफ, बिकॉज मेंटेनिंग द स्टाफ इज वेरी डिफिकल्ट. एंड गिविंग अ job to the n number of people is only possible if you have de-addiction center hospitals. I am a around 70 to 80 employees under me. So 70-80 फैमिली अपने नसीब से अपने सर्विस से कहीं ना कहीं खुश है. So revenue versus quality of care, never compromise quality. Funds are there if you are turn your institute into NGOs. Many NGOs help you out. CSR funds are there. Government schemes are there. Even Mahatma Phule scheme is there that I am trying to implement to my psychiatric hospital. Legal and licensing is not that much difficult, but one thing I always tell you that have a good harmonious relationship with the police department. तुम्हारे एरिया का जो भी डीसीपी रहेगा, एसीपी रहेगा, ही शुड बी योर फ्रेंड. इफ सीनियर पीआई एंड एसीपी डीसीपी आर फ्रेंड ना, आपके रिहाब को कोई प्रॉब्लम नहीं आता है. नो वन टॉर्चर, नो वन धमकी. सेकंड, वहां का जो पॉलिटिकल लीडर स्पेसिफिकली नगर सेवक शुड बी योर फ्रेंड. उसको ही ओपनिंग में बुलाने का, डी एडिक्शन सेंटर के कार्यक्रम को बुलाने का, दे आर हैप्पी. अरे इतना समाज सेवा किया हमने, नशा मुक्ति किया. सो दे नेवर ट्रबल यू, और वेन एवर एनी अदर पर्सन ट्रबल यू, दे कम फ्रंट. Rest licensing is not difficult. Daily routine. Dumping a patient and treating a patient is a different thing. If you want to treat the patient, make a plan, own plan, not the what your counselor tell. आपको क्या लगता है आपके पेशेंट के, मेक योर ओन प्लान. सुबह 6 बजे उठना चाहिए. आफ्टर दैट यू डू योगा, आफ्टर दैट यू डू मॉर्निंग वॉक, आफ्टर दैट इनपुट सेशन, आउटपुट सेशन, व्हाट काइंड ऑफ थेरेपी यू वांट. Generally, I use the AA वाला जो theme है, group therapy, along with the CBT, REBT. The counselor with the individual counseling and the addiction counselor, they follow their system, input session, output session, reflection. I gave them full hand because they are 24/7. आपको जो प्रोग्राम लग रहा है आप अच्छे से इम्प्लीमेंट करो. ग्रुप थेरेपी सेशंस आर वेरी इंपॉर्टेंट, स्पेशली ए मीटिंग और एनी मीटिंग मैं मेरे हॉस्पिटल के साथ टाइप किया है. दे यूज्ड टू कम एंड दे टेक अ सेशंस. स्किल बिल्ड एक्टिविटीज, evening counseling. I have kept psychologists so that they take a regular sessions. A family therapy slot is very important because family not staying with the patient. So at least of Sunday morning I am in center. जितना ही फैमिली आता है मैं उनसे बात करता हूँ. एवरी मंथ फैमिली का पेशेंट के साथ विजिट होता है. दे आर अवेयर कि पेशेंट यहाँ कैसा चल रहा है. दिस इज अ वेरी इंपॉर्टेंट एडिक्शन, रिलैप्स प्रिवेंशन. आई केप्ट वन स्टाफ टू कॉल एवरी पेशेंट आफ्टर डिस्चार्ज. उसका डेली काम है सबको कॉल करने का जितना भी डिस्चार्ज हुआ है. खाली कैसा है, क्या कर रहा है, अच्छा है. सेकंड कॉल फैमिली को, सुबह कॉल वो पेशेंट को करता है, शाम को फैमिली कॉल. सो फ्रीक्वेंट फॉलोअप्स आर वेरी इंपॉर्टेंट. मैंने उनको बोला रिलैप्स हुआ तो भी चलेगा बट इन्फॉर्म करो. सो फॉलोअप्स आर वेरी इंपॉर्टेंट. फॉर फॉलोअप्स, one thing you can do that your psychologist, they can also have a regular follow-ups along with you as a giving a medications. Support groups. Second thing I follow that OTS वाला चीज. सर मैं आई एम डिस्पेंसिंग बुप्रोनॉर्फिन सिंस लास्ट 7 years. जब हमारे एरिया में कोई नहीं कर रहा था, ठीक है, मैं मेरा रिहैब भी नहीं था. मैंने पढ़ा था कि एक सिम्स कर सकते हो, अमाउंट कम रखता था. बट नाउ आई बिल्ड कि तुमको इफ यू वांट टू रन गुड ओपीडी ना, तुम्हारा एडिक्ट दूसरे के पास जाना नहीं चाहिए. शुड बी मेंटेन अ लॉन्ग टर्म. बुप्रोनॉर्फिन इज ऑप्शन. कुछ प्रॉब्लम नहीं डिस्पेंसिंग में. फैमिली सपोर्ट, कोपिंग स्किल ट्रेनिंग. प्रॉस प्रॉस क्या है, डी व्हाट आर द प्रॉस फॉर द स्टार्टिंग अ डी एडिक्शन सेंटर. साइंटिफिक कॉम्पेंसेट केयर है, इनोवेटिव थेरेपीज है, लाइफ्स आर ट्रांसफॉर्म, फैमिली सोसाइटी, beneficial for everyone. Challenges, stigma is always challenge. First stigma is a self stigma कि साइकेट्री में ऐसा है, एडिक्ट बदलने वाले ये नहीं है. तो खुद पे जो साइकेट्रिस्ट ने स्टिग्मा लगाया ना एडिक्शन के ब्रांच को, पहले निकाल देना चाहिए. आधे साइकेट्रिस्ट बोलते हैं कुछ काम का ब्रांच नहीं है. चाइल्ड साइकेट्री वेरी गुड, वेरी गुड. एडिक्शन साइकेट्री ने क्या पाप किया है क्या? इसलिए सब जगह गांधी जी ज्यादा उधर ही है. सेकंड इज एग्रेसिव रिलैप्सिंग पेशेंट, स्टाफ बर्नआउट एंड रेगुलेटरी इंस्पेक्शंस. इंस्पेक्शन तो आने वाला है बट अभी गुड थिंग इज दैट कि एक बार परमानेंट लाइसेंस आ गया ना तो ऑडिट बहुत दिनों के बाद करना है. व्हाट नेक्स्ट, व्हाट आई कैन डू. माय नेक्स्ट प्लान इज अ टेली रिहैब मॉड्यूल्स. टेलीमानस जैसा है कि फैमिली को ऑनलाइन तुम जूम मीटिंग, व्हाट्सएप मीटिंग के साथ कम्युनिकेट करना है. बेस्ट फॉलोअप. अभी नए नए ऐप्स आ रहे हैं हर इसके, जैसे कुछ अभी सोबर रीड नाम का एक ऐप है, मतलब सोबेरिटी के लिए है. तो जो एडिक्ट है उसमें ज्वाइन करते हैं, दे डिस्कस दिस काइंड ऑफ एप्स आर देयर. कम्युनिटी आउटरीच प्रोग्राम. अभी सर ने जैसे मना अभी बताया, मेंशन किया भावे सर ने लास्ट वीक. अभी डोंट लॉस एनी अपॉर्चुनिटी टू सेलिब्रेट मेंटल हेल्थ. अपना कोई भी दिन है ना अपने कैलेंडर में लिख के रखने का. कोई भी साइकेट्री का दिन रहेगा, सेलिब्रेट करने का. और वेयर यू सेलिब्रेट, नॉट इन योर होम, नॉट इन योर क्लिनिक, केक काट के रील बना के नहीं. गो इनटू द सोसाइटी, टीच देम, टॉक विद देम. अभी हमने क्या किया कि मेंटल हेल्थ आया था तो मिशन चैतन्य लॉन्च किया पुलिस के साथ, डायरेक्ट सीपी सर को. और डरने का नहीं किसी से मिलने के लिए. डायरेक्ट जाने का सीपी सर मैं ऐसा हूँ, मुझे ऐसा करना है, मैं चाहता हूँ कि अपन वसई विराट ड्रग फ्री करेंगे। तो सीपी रेडी, अरे क्या कंसेप्ट है, उन्होंने मुझे सब पुलिस दे दी है। सो व्हाट आई डू कि मैंने 12 स्कूल को कांटेक्ट किया, बोला कि पुलिस कमिश्नर ने बोला है तुम्हारे स्कूल में होना चाहिए, और बड़े बड़े स्कूल किए। सो 12 psychiatrists went into 12 school along with one senior PI. Police will talk on the legal aspect of psychiatry, legal aspect of addiction. We talk on the medical aspect of एडिक्शन। हमने 2000 स्टूडेंट्स कवर किए, उसका साइंटिफिक रिसर्च में भी कन्वर्ट किया। एक पुराना जो रहता ना पैर बचा था पेपर पब्लिश करने का नायर का, वो पैर भी कंप्लीट हो गया। टाइप विद नायर एंड मेक अ स्टडी, वो नायर में अभी पब्लिश होगा वेस्ट जोन के साथ। भावे सर ने मुझे बहुत थ्रू आउटली सपोर्ट किया इसमें। सो सेकंड थिंग इज द इंडस्ट्री एंड कॉलेज कोलेबोरेशन। ठीक है, कोई भी एडिक्ट पेशेंट आएगा ना, उनको बोलने के हमारे पास सब सर्विस है, वो तुम्हारे पास लेके आएंगे। इफ यू डोंट टेल ना, तो बाकी लोग बोलेंगे कि हम सर्व कर रहे हैं। सो शाय होके कुछ मतलब नहीं है। ठीक है, अगर फ्लाई करना है तो शाय का कुछ मतलब नहीं है। माई फिलोसफी, रिहेबिलिटेशन इज नॉट पनिशमेंट, इट इज अ रीवायरिंग ऑफ माइंड टू क्रिएट अ मीनिंगफुल लाइफ। इट्स नॉट पनिशमेंट। रिहाब में डाल दिया उधर, पनिश नहीं है। पेशेंट खुश होकर जाना चाहिए, बहुत अच्छा रिहाब था, बहुत मजा आया मजा आया। फाइनल टेक वे, don't just treat the illness, build a system of care. Hospital heal, but rehabilitation transform. Don't be just psychiatrist, be a mental health activist. And the love and take interest in the addiction psychiatry. Addiction psychiatry has a bright future and peaceful lives. To all young mind, either it is a day one or one day. If you started from day one day will come. फाइनली मेरे एक प्रोफेसर का एचओडी का सवाल मुझे अभी भी याद आता है, व्हाई यू चूज साइकेट्री। सर ने मुझे एक बार बोला था कि दिस इज मिथ कि हमने साइकेट्री चूज किया है, गॉड चूज इन साइकेट्री। सो नाउ आई रियलाइज व्हाट आई गॉट इन साइकेट्री इज इनर पीस। व्हेन यू सेव वन फ्रॉम एडिक्शन, यू सेव द एंटायर फॅमिली। एकाचं व्यसन संपलं, घराचं अभाव उजळलं, तो वाचला म्हणून पुन्हा घरटं फुललं. सो थिंक अबाउट दॅट. थिंक अ ब्रॉड स्पेक्ट्रम थिंकिंग इज व्हेरी इम्पॉर्टंट. अँड लास्ट लिस्ट, मी नागपुरात आहे, मी आलेलो आहे, IPS ची AIIMS ची युती करून आलेलो आहे. मी पुन्हा येणार, पुन्हा येणार. तुम्ही नाही बोललो तरी पण येणार. थँक यू.
You are not just a psychiatrist, but you are the hero of the society. It is need a good dedication, and you always get satisfaction from your work. The story is the same everywhere at Nagpur, at Vasai. The same story happen in our city also. Uh, y- the main thing that is you elaborate you everything in a very good manner and jolly manner. Thank you very much. Any questions?
Yeah, thank you, Suresh. You played like Surya Kumar with unconventional shots. So, uh, I was curious to know that what is the financial viability as well as the risk reward with all the legal systems and all troubles we go through.
If you dream more, if you want to achieve more, start a psychiatric hospital and rehabilitation center. Like OPD is like OPD is like roji roti. If you want to enjoy feast, you have to come to this segment. Admissions, everyone don't have 100 का OPD. ठीक है, but if you group together 20 का OPD and if you run a hospital ना, finances as a personal finances बहुत भारी है. Second thing, when you running hospital, when you running a rehabilitation center, own center ना, you can family को बहुत तुम सस्ते में भी कर सकते हो. I kept for my rehab charges from 12,000 to 16,000 per month. 12,000 से 60,000. So flexible slots are there. General wards, deluxe room, semi-deluxe room, VIP rooms. So financially definitely good. From the Sarkar point of view, if you want the license, that not much trouble. Okay? Definitely is a rewardable. Okay? You have to enjoy it because it's stressful also. You get night call कि अरे सर पेशेंट सोया नहीं है, तकलीफ वाला है. So divide your work. भाई 2 दिन मैं कॉल पे रहूँगा, इधर हमने किया है रेसिडेंसी में, दैट वी डू इन रेसिडेंसी कि 2 दिन मैं कॉल देखूँगा, 2 दिन तू देखेगा, 2 दिन मुझे ट्रबल नहीं करने का। स्टाफ को क्लियर कट इंस्ट्रक्शन देना। 1 दिन अगर हम देते हैं, अगर 6-7 पार्टनर्स है, देन वी कैन रन इफेक्टिवली, क्योंकि टीम इज देयर ना। प्रॉब्लम क्या होता है कि पेशेंट्स आर घूम के अपने ही पेशेंट्स रहते हैं। और सेकंड थिंग, अगर टीम रहेगा ना तो सपोर्ट रहता है, वी गेट अ करेज, वी टेक अ मोर रिस्क। और कौन सा बिजनेस नहीं सर जिसमें रिस्क नहीं है? टेल मी वन बिजनेस। पानी पूरी बेचा तो भी रिस्क है। सो व्हाई नॉट टू टेक रिस्क? रिहा बोले रिस्क ले जिनके पास लाइसेंस ही नहीं है, डिग्री नहीं है, कुछ नहीं है। सो व्हाई नॉट वी? इफ नॉट वी देन हू? आपण नाही तर कोण? आणि आत्ता नाही तर कधी? इट्स रिवॉर्डिंग. और आसान है तो आसान है, आसान झालेलं आहे. नागपुरात बनले तुमचं, आसान आहे ना.
Uh, having said that, all this, with all due respect, my very frank question, practically, how much is the profitability ratio at the end of the annual budget of our rehabilitation center?
सर आईटी का
To be
रेट
very
बढ़ेगा.
frank, sir, I want a frank answer because I am also associated to that. Depends on area, I know that, but what is the profitability ratio at the end of the day?
So you see, this is rehab. Rehab is very profitable. Rehab is like LIC policy. Patient will come. You have to be good policy seller, good policy server, and you should be good follower. Rehab never be कि flop हुआ ऐसा नहीं है. Rehab never flop because patients stay for months. You get number of patients ना. Psychiatric setup may get in trouble. आज तुम्हारा ओपीडी नहीं है, 5 दिन तुम घूमने गए, 10 दिन तुम फॉरेन चले गए, who will admit? यहाँ ऐसा नहीं है. Patient will come, stay there for 3 months. We have 90 days program. तो 3 months में patient build होते हैं. Initially 6 months or 1 year is a trouble, but after that is a success. Not a single de-addiction center is in loss in Mumbai because of the population. अभी विरार का total population is 27 lakh. 27 lakh population है. वसई विरार का खाली. And we are getting a draining. We are getting patients from all over Mumbai, Gujarat. So drain is there. If drain is there, this run. और नागपुर में भी रन होते होंगे सर. We don't know because many non-medicos are running it. Even if right now I am finding some medicine people taking interest. One physician called me, पाटील अजून एक टाकायचं आहे का? I have place in Mira Road. So they saying as a their investment. So अपना रोजी रोटी है. So everybody try it at least. If you don't try, then कैसे पता चलेगा कि चलता है कि नहीं चलता है? पहले पानी में उड़ी तो मारो. सर अभी इधर बोलूंगा तो आईटी का रेट आएगा ना.
नहीं, sir. I'm just asking percentage wise. I don't want the figures.
सर प्रॉफिटेबल, अच्छा प्रॉफिटेबल समाधान है. का गाड़ी का कलर, गाड़ी का साइज बड़ा हो सकता है, घर का साइज भी बहुत सारे स्क्वायर फीट में बड़ा हो सकता है.
Quite a diplomatic answer. Thank you, sir.
Sir, I'm not practicing in Mumbai. I'm practicing in Palghar district. Palghar is a small place than the Nagpur. Palghar is a small district than the Nagpur. Sir, ऐसा लगता है कि प्रॉफिटेबिलिटी या है. हाँ, नंबर ऑफ साइकेट्रिस्ट आर मोर इन नागपुर. नागपुर में बहुत सारे साइकेट्रिस्ट है. ठीक है, कंपटीशन में भी वेरी हाई नागपुर. इन माय एरिया वसई विरार वी हैव 12 साइकेट्रिस्ट ओनली. 27 लाख के लिए खाली 12 साइकेट्रिस्ट है. दैट में भी डिफरेंस. अगर बहुत सारे साइकेट्रिस्ट है, बहुत सारे साइकेट्रिक हॉस्पिटल है, देन इट माइट बी अ प्रॉब्लम. पेइंग कैपेसिटी इज ऑल्सो इशू. Sir, if you go away from 10-15 kilometers from Nagpur, nearby villages, taluka place, where you can travel at least 20 kilometers a day, good road, then it's possible. If you are trying to run a de-addiction center for 10 bed, 20 bed, it's not profitable. Huh? You always think about 100 bed. Because their patient don't charge you 60,000 रुपए महीने का, लाख रुपए महीने का. They will pay up 15,000, 12,000, 20,000. So that cumulative amount is important. If you have 100 patients and the cumulative amount, give a profit. but give at least handsome profit equivalent to our OPDs.
Experience about picking up patients. Many times patient is not ready, relatives request, and many times on very first visit we are also not sure about history.
So involuntary admissions are very risky thing. Okay. But before that, we take a consent form, a family consent before admission, give our prescription. Yeah, if the old patient or other psychiatrist prescription there, then it is a crystal clear. Many times we'll already inform the family. The अगर family में disputes है, if the patient is not ready और आपका बहुत सारा problem है, then we'll discharge. 7 days, 5 days observe के बाद we will give discharge. So this kind of where we feel that more risk ना, वहाँ थोड़ा सा तुमको निकलना है. Not every patient you have to keep. सबसे पहले ना सिलेक्शन ऑफ पेशेंट इज वेरी इंपॉर्टेंट. किसको लेना है, किसको नहीं लेना है. दोज हु आर द लॉयर्स आर द वर्स्ट पेशेंट्स. द फैमिलीज विद द लॉयर्स, वो किधर ना किधर गोची करेगा, ट्रबल करेगा. ठीक है. डॉक्टर हिमसेल्फ एज अ बैड पेशेंट. कोई डॉक्टर है उसको ट्रीटमेंट लेना मतलब बहुत प्रॉब्लम है. सो यू हैव टू सिलेक्ट योर पेशेंट वाइजली, किसको लेना है किसको नहीं लेना है. सर लीगल सपोर्ट ऐसा कुछ लीगलिटी में है ही नहीं कि इनवॉलंटरी वॉलंटरी बोलते ही है, सब वॉलंटरी आने के बाद डिस्चार्ज के टाइम सबका साइन लेने का. तो बिकॉज इसमें तो ये तो बहुत डिबेटेबल टॉपिक है, इनवॉलंटरी एडमिशंस.
Started the topic ki, what about we do about a patient who is not ready to admit. First thing, majority of the admissions are pick up, as of by your personal experience, 95% of the patients are pick up.
Involuntary pick up.
They are all involuntary admissions. After that, as you said, ki we have to take a form on the voluntary border. There was one patient, affluent society in India, sorry, Nagpur. His brother was sitting in Delhi. Fortunately, in our case, for that patient, nominated representative wife signed as a nominated representative. He stayed in the rehab for 5 months. Till the end, he did not sign on the voluntary board. After 5 months, his brother started creating all the troubles for us. We want discharge. How can you keep the patient without his permission and all that? So we explained him, see, this is not the way. This is an involuntary admission in special need. And wife was the nominated representative. If at all wife says that I want discharge, then and only then we can discharge. We cannot discharge on your behalf saying that you are brother. He went on to file a case up till almost in a court. He complained it at mental health review board. That case went up to mental health review board. Then the committee was set up and everything. The only thing which was in our favor in that case, that the wife did not shake up till last ki okay, I am the nominated representative, so I am not going to discharge him at this point of time. So that went on for 3 to 4 months further. Finally, we discharged him when the wife said ki anyway I'm going to divorce him, so you please discharge him. So that was the case. It happens. It went up to, I think, in that case, Puthe sir is there. So उन लोगों ने बहुत हेल्प किया. मेंटल हेल्थ रिव्यू बोर्ड की जो कमिटी थी, वहाँ के जो जजेस थे और जो वकील भी थे उसमें इन्वॉल्व, उन लोगों ने भी हेल्प किया. वो सब राइटिंग में हुआ, लेटर्स बाजी ये वो कि why you require to keep the patient. Then all the documents were submitted. Then monthly review, weekly review, of the detail. I myself typed it and created and then all the documentation. So this जो एक आधा कोई ऐसा एफ्लुएंट सोसाइटी का रहता है, वो उन्हें सीपी तक कंप्लेंट की, सब जगह पे जाके है. तो वो हुआ, लेकिन अल्टीमेटली देन वाइफ नहीं हिली. वाइफ वाज इन आवर फेवर कि नहीं, आई विल नॉट चेक अप इनटू दैट सिचुएशन. दैट्स व्हाई इट वेंट स्मूथली. So that was the personal experience I wanted to
What
share
I
with
do
you.
now, कभी ऐसा many time I feel that नहीं complicated matter है. I mail to MHRP पहले ही दिन. ठीक है. बीच बीच में करते रहता हूँ मेल. मैंने स्टाफ को बोला है when you think that ना ये complicated है, so we'll discuss. We are panel of psychiatrists there. मैं हूँ, सावे सर, तांडल सर है. वो MHRP को मेल करते हैं. ठीक है. So we are in the safe zone. Second thing, we always take advice from the legal advisor क्या होना चाहिए. I call Dr. Sanjay Kumar sir, sir ऐसा ऐसा मैटर है, क्या है. He will guide कि ये तो रिस्की है, निकाल दे उनको. So this kind of, sir, this kind of things are going to happen क्योंकि ये अपना मेंटल हेल्थ, उसका लॉ, ये सब सब कॉम्प्लिकेटेड चीजें हैं. वो इट इज कॉम्प्लिकेटेड, काम नहीं करेंगे कैसा चलेगा. वी हैव टू हैंडल समहाउ, चलना है.
ऐसे में अधिकारी समझदार रहे तो अच्छा रहता है।
अधिकारी सर
Otherwise,
समझता है, कुछ नहीं समझता है तो दूसरे तरीके से समझ जाता है।
अदरवाइज बहुत डिफिकल्ट हो जाता है।
Thank you so much, sir, for that very insightful and practical talk. I would like to request the chairpersons of the session to felicitate our speaker. Now I would like to call Dr. Praveen Nokhare to please felicitate the chairpersons for the session. We would now begin a much anticipated panel discussion. Before we begin the discussion, a few of our volunteers will go around the room, and I would request all of you to write down your questions for the panelists, and please give it to them. So our junior residents in Department of Psychiatry at AIIMS, Dr. Mithil, Dr. Kaushik, and Dr. Devendra are volunteering and taking the questions. So you can write them down on a piece of paper and they'll come around to collect it. So our panel discussion will be on navigating challenges in addiction medicine practice, which will be moderated by Dr. Neha Bhave Salenkar. Dr. Neha is a gold medalist in her MD exam in Goa University. She also has a gold medal in medicine from Maharashtra University of Health Sciences, a certification in child and adolescent psychiatry from ICAM, and two courses from the Indian Institute of Management in People Management. She has extensive experience in conducting seminars and talks, including corporate seminars for clients like Drip Capital, Exaware Tech, Kaitan and Co. And she's also a columnist for the newspaper Lokmat Times. She's also a member of the executive committee in the Nagpur Epilepsy Association and a member of the Women and Child Mental Health Subcommittee, IPS West Zone branch. I would kindly invite her to the stage to introduce the panelists.
Very good afternoon, everyone. I welcome you all to our star-studded panel discussion for today. It's the last session in a series of wonderful sessions. Um, it's going to be a difficult act to follow up after Dr. Patil's extremely candid and arousing session. I would now like to introduce my panel members. Right. Dr. Amol Busare, he's completed his MBBS from GMC Nanded and post-graduation from Grant Medical College, Mumbai. And he's practicing at RMH Thane from 2021. He's also attached to several hospitals. He's worked as medical officer at PHC Daheli Thanda, was house officer at GMC Aurangabad. He's been medical superintendent at Rural Hospital Palam, also medical officer certificate program at KEM Hospital. Um, He has several achievements, including Best Resident Award in JJ Group of Hospitals. He's been a member of State Mental Health Task Force for COVID-19 and a member of International Association of Sexual Medicine Practitioners. I welcome you, sir. Our next speaker today is Dr. Vineet Patel. Sir is assistant professor at Department of Psychiatry in AIIMs, Raipur, and he's had his training at NIMHANS, including MD, a PDF in addiction medicine, and a DM in addiction psychiatry as well. He has several affiliations, including ISAM certified in addiction medicine. He's the assistant editor for the APSI newsletter. He's a member of publication subcommittee ISAM. Next, he's also the life fellow of AFCI, APCI. He's member of addiction psychiatry section of several committees. He has won several awards, including the Best Thesis Award at ADICON. He's the winner of ADIQuizon quiz, registration bursary at ISAM Global Congress, and has won the Inebria Scholarship. I welcome you, sir. And our third speaker for today, we've been lucky enough to hear Sir in the morning as well, Dr. Atul Ambekar. He's a professor and National Drug Dependence Treatment Center, AIIMS, New Delhi. His area of special interests include drug policy, harm reduction, epidemiology, and health system strengthening. Sir is Secretary General for the Addiction Psychiatry Society of India. He's a member of Board of Directors for the International Society of Addiction Medicine, also member editorial board for International Journal of Drug Policy. He's honorary fellow of School of Criminology of the Hong Kong University. He has multiple publications. He's also a resource person for several organizations. Sir is principal investigator for the National Drug Use Survey 2019 and 25 by Government of India, and has won the BMJ South Asia Award for Non-Communicable Disease Initiative for the year 2016. Sir is also National Resource Center's won the award for Outstanding Contribution 22 and the Distinguished Humphrey Fellowship Award in 2025. We welcome you, sir. Mic. शुरू है? Okay. Uh, we'll be starting directly with the questions, and if time permits, we'll be taking some audience questions at the end. Yeah, you can. My first question today is for Dr. Patel. Uh, so, can you please tell us? Dr. Patel spoke a lot about setting up a private de-addiction center, but can you speak about challenges in setting up a government de-addiction center?
First of all, very good afternoon, everyone. So, thank you for, first of all, inviting me and giving me this opportunity to talk about uh, challenges in addiction medicine on this occasion of Drug Abuse and Illicit Trafficking Prevention Day. I thank Secretary Society Nagpur as well as West Zone and Department of Psychiatry, Dr. Suyog, AIIMS Nagpur also. And I'm more than humbled and thankful to share the dais with esteemed mentors, teachers, and surprisingly my seniors also from my undergraduate days. So I'll try my bit to, if at all, I can add on to whatever has been talked about today and shared about tremendous and vast experiences by everybody here. So, as far as setting up government de-addiction centers, uh, we more technically call it addiction treatment facilities nowadays, first of all, and then it's a good opportunity to understand a lot of various challenges which we can keep on talking about. But I would like to pay attention on two most crucial part. One, as all of us might be knowing, one is with respect to logistic part, especially in setups like government health hospitals, government setups. Space allocation for running addiction treatment facility is one of the biggest bottleneck currently. If we would talk about couple of years back, definitely we could have pointed fingers that there are policy level issues, there are lack of funding, there is lack of mentoring or guiding. But right now, at this point of time, under a tremendous program of drug de-addiction and prevention, I don't think that has been a limiting factor anymore. And now the issue comes to how those resources are being utilized or being channeled for the bigger picture of public health service. So the first biggest challenge which I perceive and I have been facing as well is space within the government hospitals. Now, second issue comes, so then why is that? If that is the scenario, then why we are facing that challenges? Different places, different setups have uh, their own issues. For example, the most common issues which a lot of places or my colleagues are facing. First of all, a lot of regulatory approvals. Although on paper it sounds very, very smooth or very easy to acquire and start addiction treatment facility, but in the ground reality that does not happen. Uh, Many of my colleagues have mentioned that maybe low prioritization in entire healthcare system for addiction treatment facility. You can name it a stigma, you can name it lack of awareness, you can name it uh, doesn't look good on paper. I mean, the way you want to name it. But if you conclude it down, if you narrow it down, it comes to this. The second issue which we face is having a consistent workforce. For example, under the aegis of ATF and scheme by MOSG, the current workforce are being paid uh, almost bare minimum. And the second is the required qualification, obviously, because we are at that juncture of timeline where we don't have many numbers of trained experts either in medical field or in the psychological field as well. So that comes to the problem. We need to keep that, but the qualification for the so-called human power is so basic that ensuring quality becomes an issue. And the job style or job type, you can say, most of the times are contractual. They don't continue in the places. So at the ground reality, the nodal officer, who has to be one of the regular employees, faces a significant challenge in maintaining the same quality of services. You ensure the quality, then again staff changes, and then cycle continues. So a lot of energy in terms of time as well as in terms of human effort goes on in recreating the same resources which could have been more permanent.
Right.
So these are two this biggest thing which I think are the currently among many other challenges.
Right. So paucity of resources, government will. Right. So Dr. Busare, my next question will be for you. This was briefly touched upon in the previous session as well, that there's a lot of concern, especially in media, also about detention against will, and even worse, inhuman treatment within the centers. Like every now and then, we see horrific images coming up of inmates being beaten up or treating in an inhumane manner, being locked up. So, what are the policy measures in place to check this?
Definitely. Thank you very much. First of all, I will very thankful for inviting me as a here as a panelist. And I think I'm only here from government setup. Bhumne sir is absent. Basic thing that inhuman treatment that Suresh Patil has addressed na. In Mental Health Care Act, there is a specifically section 90 admissions and discharge chapters में section 90 जो दिया है उसमें क्लियर कट मेंशन किया गया है कि कोई भी पेशेंट को अगर आपको बियॉन्ड 30 डेज एडमिट करना है तो आप उसको सेक्शन 90 में एडमिट करना चाहिए. So whenever you admit a patient involuntarily against his will, you should write on paper that patient is admitted under section 90 and it is beyond 30 days. For more than 30 days, you have to inform MHRB prior to 3 days कि हमको इन्फॉर्म करना है. जैसे उन्होंने मेल कर दिया है गवर्नमेंट को कि हमें इस पेशेंट को डी एडिक्शन के लिए. अल्टीमेटली मेंटल हेल्थ, दैट इज लॉ फॉर मेंटल हेल्थ एस्टेब्लिशमेंट्स, and all de-addiction centers and mental hospitals, even civil hospitals who provide services, it may be government, it may be private, they comes under Mental Health Care Act 2017. So if you follow strictly the law, then it will be very much feasible for everyone to take admission. Second thing, according about that for inhuman treatment. That inhuman treatment, I think we should not never utter a word inhuman treatment, because we are human, and public is always uttering us ECT is according to public ECT is inhuman treatment. So exactly the definition of inhuman treatment is not just chaining or restraining. Physical restraint is not inhuman if it comes to his life or it comes to others' life. So we have to clearly mention to relatives that inhuman treatment is that we should that inhuman treatment is happened where there is no psychiatrist. So there is a strict law about mental health establishment in section 65. What are the protocols that Suresh Patil has clearly mentioned? Ki psychiatrist chahiye, psychologist chahiye. If that criteria is fulfilled and regular audit from MHRBs or that when the government set up officials has done, then it will be very feasible to check on that inhuman treatment. Not only this, we have to create awareness about Mental Health Care Act, and there are clause of punishments also. That punishment is not only up to fine. Fine is very much fine for everyone, but that fine is not only fine; it may be turned into imprisonment, and that we have to create awareness. Here are much more. Today we are sitting here as psychiatrists, but we exactly no one can say that I am fully aware of Mental Health Care Act. Now, what are the provisions? How much chapters? How much sections? Ultimately, we say that we are not lawyers and we should take help of lawyers. But the picture is that when we go to court, लॉयर को अपने को समझाना पड़ता है कि सर हमारा ये केस है, ये सेक्शन के अंडर ऐसा है, ये फिर जाके वो केस लड़ते हैं। सिर्फ काला कोट पहनने से वो लॉयर को मेंटल हेल्थ केयर एक्ट के बारे में पता नहीं है। सो वी कैन गवर्नमेंट जैसे कुमार सर इज ऑलवेज गाइडिंग अस as a legal and psychiatric doctor. So we should have aware about forensic psychiatry also. Then it will be a good check. Second thing, फिजिकल रिस्ट्रेन की जगह अगर आप केमिकल रिस्ट्रेन करेंगे, वो भी दैट विल बी वेरी फाइन। सेकंड, अगर इसको चेक बिठाना है तो सीसीटीवी का अगर रिलेटिव्स को आप लोग जैसे अपना डी एडिक्शन सेंटर है, उस डी एडिक्शन सेंटर में आपने सीसीटीवी बिठाया, रैंडमली वी विल चेक द ये। थर्ड थिंग, each and every de-addiction center should have notified the numbers of MHRB. MHRB को इन्फॉर्म करना है, MHRB को इन्फॉर्म करना है, लेकिन कहाँ करना है? फोन नंबर किसके पास है? किसी के पास नहीं है। तो इट इज कंपल्सरी फॉर ईच एंड एवरी de-addiction center to notify their phone numbers and mail IDs in a प्रॉपर। जब फ्रंट में ही आते तभी उनको दिखना चाहिए, उन्हें पूछना चाहिए क्या है, कंप्लेन के लिए ये जगह है। थर्ड थिंग, इन द मेंटल हेल्थ केयर एक्ट राइट्स ऑफ पेशेंट में क्लियर कट मेंशन किया गया है कि भाई हमें किसी भी लीगल एड के सर्विसेज चाहिए, मेरे पास पैसा नहीं है, मैं वकील हायर नहीं कर सकता हूँ, इन्होंने मुझे मारा है, कुछ भी किया है, तो नालसा दैट इज नेशनल लीगल एड सर्विसेज है जो फ्री ऑफ कॉस्ट अपने पेशेंट्स को प्रोवाइड किए जाते हैं। सो दीज ऑल थिंग्स आई थिंक वी शुड हैव great check on that in treatment which we call as inhuman. Thank you.
All right. Thank you, sir. So moving from the policy law angle to the policy angle and back, Ambekar sir, how do punitive drug laws impact people with substance use disorder, and more specifically, how does it interfere with treatment-seeking behavior?
Right. So, since morning, one term has often been used in context of substance use disorder, that is stigma. And that stigma actually emanates from this attitude of the society whereby drug use is seen as a deviant behavior, which society decides which of those drugs are acceptable to the society and which are not. So at this moment, there are some psychoactive substances which all of us not just use but celebrate. We propagate them, we serve them. We consumed one right now in the break. There are some psychoactive substances which are allowed and which are expected to be served and consumed in the evening hours. I'm talking of alcohol here. There are some other psychoactive substances which society has collectively decided that they are so bad that people using them should be put in jail. And a lot of these attitudes have actually been shaped not by just the scientific understanding of what is harmful and what is not, but by the colonialism and the racism. So, substances which have been used, produced, cultivated, culturally acceptable manner by us, the global south, the brown people, brown and black people, the poor people of the world, those substances have been vilified and demonized. So, like we have been growing and using cannabis, religiously sanctioned, socially sanctioned in our part of the world. Opium use has been culturally ingrained in many communities in Rajasthan, UP, and MP as part of their culture. That has been vilified and criminalized. Similarly, coca bush cultivation and its culturally accepted use is very widely prevalent in Latin American countries.
So these were the substances which were branded as narcotic and very dangerous and should be banned and criminalized. And on the other hand, alcohol, tobacco, these were the white countries which were producing it, marketing it, and that's how they were propagated. So that is the root cause of this. And we Indians, we always love to internalize the colonial masters have sort of forced upon us. So our current attitudes about things like substance use or even homosexuality have been shaped by the colonial impression on us. So that's the reason why this criminalization of drug use is rooted in that kind of attitude. And also simultaneously, the establishment of the society, when I say establishment, I mean not just the government, but the larger social and religious establishment as well. What is their take and their attitude about how to control the deviant or undesirable behaviors in the society? So, a society which favors more authoritative kind of disciplinarian measures for its members, they will always favor much more criminalization. A simple example is alcohol. It's not that alcohol consumption has been found to be has been promoted as very good in ancient Indian culture, traditional Indian culture, right? It is frowned upon, but it was allowed in certain contexts for certain people. In Islamic cultures, it's totally prohibited and hence it's criminalized, and that's the root of it. So all these factors actually lead to what extent the drug will be criminalized, and unfortunately, our NDPS Act when it was formed, we also followed that Western colonial model of undesirable behavior. That means it has to be criminalized. In the eyes of the establishment or law, if something is banned and made a punishable offense, we reduce the probability of engaging in that behavior. That's the reason why homosexuality was criminalized. That's the reason why self harm attempts, suicide attempts were criminalized. So these are the three behaviors which were criminalized, which fall under the purview of psychiatry. For two of these, the stand of us as professionals has been very clear. Homosexuality should not be a crime. I think most psychiatrists will agree and have passionately advocated for it. Similarly, suicide attempt should not be criminalized, and our MHCA 2017 reforms have, to a large extent, taken care of it. This is one issue. Criminalization of personal consumption of substances under the NDPS Act, on which we as professionals collectively need to get our act together. And this criminalization is behind that stigma to a large extent why it is seen as so much of a deviant behavior, which lies behind all the harms of the drugs. So the harms caused by substances could be number one because of the psychoactive and physical effect of that substance itself, and also the harms can be caused by the social attitude towards this substance. So the most harmful consequence of cannabis is only that you can get arrested out of it, right? Otherwise, people can consume cannabis for 40, 50 years. The biological, physical harms will be very minimal. The biggest risk is that you can get caught with it and then you are in jail for 1 year. So I seriously believe that we as psychiatrists need to have collectively as one of these agenda points of bringing about legal reforms. Thank you.
Thank you, sir, so much. Dr. Patel, coming back to a clinical area, and we want your experience on this. Can you talk about challenges faced with women's rehabilitation?
Thank you, ma'am, for that very important and very pressing question. So, as far as women and substance use is concerned, uh, I would like to talk about three things. First, uh, I would like to continue on the topic which sir had led about stigma. So, substance use and stigma goes hand in hand. But the moment we talk about women and substance use, the stigma becomes doubled, or let's say even two-hit hypothesis, or you can say double-edged sword or something like that. What do I mean by that? There is a stigma for using substance, which is common even with the males, but women with substance use have also faced stigma and very well documented in the literature also, even for seeking treatment for substance use disorder. That also goes as a perceived stigma and also an experienced stigma at various treatment facilities. Uh, they are being more quote unquote judged as again labeled as a bad culture lady or woman, or quote unquote, again, I would like to use this, they have been called unfit to mother, unfit to care for a child. And the list goes on for the words which are being used, which does not happen in case of men with substance use disorder. So, not just using, in fact, seeking treatment also becomes very stigmatizing in case of female with substance use disorder. The second point, which I would like to mention here is, what are we doing in an attempt to reduce the stigma, which is differentially high among women as compared to men? So, I was very surprised by Dr. Suresh sir's setup, which I personally know as one of the women-only private de-addiction facility. And I was only aware about one more government community clinic, which under leadership of Professor Atul has started. This is a community clinic in Pardabag one of the area in Delhi. Apart from these two, especially in government setup, I am not aware about any women only treatment facilities for substance use disorder. And I would like to mention, especially the clinic at the Pardabag is also being catered by female only staff. The doctors are all female. Currently, the counselors are all female. Even the housekeeping staff and security member till that level, all the staff at that particular clinic are female. And further detail can be, if time permits, can be discussed with Sher. The second was Dr. Suresh's setup, which was, I mean, when Sir mentioned that at that particular place also it is being short staffed, or being inadequate to cater to the population. That tells us, and the Sir's vision that tells us the need of an hour about having a so specific treatment facility just for a special population. Adding on this, all this is a integrated setup for women substance use disorder. What do I mean by that? The moment you talk about women substance use disorder, a lot of other risks associated with women substance disorder, all of us are aware. High risk of sexual transmitted disease, sexual fever for substance procurement, which is not that common. It is common, but not that common in males. Uh, High risk of psychiatric comorbidities, and then also custody with respect to child. Despite all this, there is a very specialized phase in woman's life is pregnancy. And a lot of women with substance use disorder unintentionally end up being pregnant while seeking treatment, and they come to know about it during that point of time. So, where are the places where do we have integrated obstetric care, a child care facility, or at least neonatal care facility along with substance use disorder? So, that model has been very well established, at least in some Western countries, Australia for one, UK for another. I personally know which has up and running, and I'm yet to see such integration even at general hospital setup. We don't have integrated OPD for such facilities. We do liaise with the department ki, okay, we refer patient to this department, that department, try to liaise in person with the concerned faculty, and so forth. But let's suppose, is there a such facility existing where at one roof the woman can seek all the concerned health care, which is very well common if I ask you with respect to diabetes. People even can get their neuropathy checked in the same OPD on the same day, which is lacking for this population. The third and last point is, so what are we doing about it? So that needs to be debated a lot from here on, and I urge people that that can be also one of the model when Dr. Suresh is planning for his next big setup. If sir believes.
All
So
right.
thank you.
Thank you so much. And I think maybe one of the challenges could be financial constraints also, especially for
Uh,
women.
Definitely, ma'am. I not agree more than that, but I was trying to, seeing from a perspective which is more in females as compared to men.
Right.
Financial constraints are also very much prevalent or problematic in the moment, men substance use disorders are concerned. But I do agree with your point. If we add a cultural angle to it, still in India, if we take about the culture, the main breadwinner are the men,
Men.
and especially in that population. And then, in fact, there has been a very well good section of female treatment seekers who use substances after the partner uses them.
Right.
Need not to be married couple, even the partners. So first the male partner will use, and whatever is left out or used paraphernalias, they are being used by so-called, and that's being the reason of high prevalent of medical comorbidity and so on.
Right. Right.
Right.
So, Dr. Busare, because we spoke about the financial issues, what are the sort of de-addiction services which are covered under insurance policies?
First of all, insurance companies cover always physical illnesses, but since after Mental Health Care Act comes, in the Mental Health Care Act, again in the Chapter 5 Rights of Patients, in that section 21 and clause 4 clearly mentions that each and every insurer company should give insurance to each and every mental illnesses as a physical illness. And after that law comes, IRDA, that is Insurance Regulatory Authority of India, has clearly mentioned we should give insurance to all mental illnesses. But when insurance company or when we take insurance, we never read that you just review, sir, sign karo, sign करके देते हो. तो first of all, we should get aware that insurance company में अपने को पूछना चाहिए कि हमको कभी कुछ होगा नहीं. ये चीज अपन पूछते नहीं. Not only in mental illnesses. Ironically, insurance company always gives insurance to alcohol level disease. बट दे नेवर गिव्स डी एडिक्शन का इंश्योरेंस. डी एडिक्शन का इंश्योरेंस में कब देंगे? अगर तुमको सिरोसिस हुआ है, कुछ हुआ है तो देंगे, लेकिन वो होने के पहले जो इंश्योरेंस चाहिए वो नहीं देते. तो ये जो है बहुत मोस्ट ऑफ द इंश्योरेंस कंपनीज, सो वी हैव स्टार्टेड फ्रॉम गवर्नमेंट. गवर्नमेंट ने जो इंश्योरेंस कंपनी, गवर्नमेंट हैज ऑलवेज गिव्स महात्मा ज्योतिबा फुले योजना, and that Mahatma Jyotiba Phule Yojana, we have covered now 4 illnesses. That's schizophrenia, bipolar disorder, and we have covered 2 procedures, that is RTMS is there and ECT is there. We are giving insurance to them. So when we have to give insurance, we have to add diagnosis, dual diagnosis, bipolar disorder with substance use disorder. In that case, we have to we can give insurance to them. And I think according to me, some insurance companies are clearly giving insurance for IPD services. They are not giving insurance for OPD services. But the main thing in de-addiction treatment lies in after care, that after the discharge from rehabilitation, as we all know, the acamprosate drug, it's very costly. तो पेशेंट बाद में सोचता है कि इससे अच्छा मैं दारू पीऊं इतना कॉस्ट भर के. तो ये जो चीजें अगर इंश्योरेंस कंपनी को आप क्लियरली पूछोगे, कुछ इंश्योरेंस कंपनीज देते हैं, और आईआरडीए के साथ अपने को थोड़ा राइटअप करना पड़ेगा आईपीएस के थ्रू, मतलब इंडियन साइकेट्रिक सोसाइटी के थ्रू, गवर्नमेंट के थ्रू. So definitely a day will come that each and every de-addiction service will come under insurance, and we will set up a much more private de-addiction centers like that. Thank you.
All right, thank you, sir. So, because we have Ambikar sir here, I have to ask this questions. This question. So, what are the amendments you think are required to the NDPSA?
Right. So basically, NDPS Act it came about in 1985, and it came about almost as in a hurry. Why? Because in 1961, when India signed the UN International Convention on Narcotic Drugs, at that time India was given a 25-year grace period to reform their laws so that particularly cannabis and opium use can be criminalized. Till then, they were not criminal act to use charas or ganja. So India got this 25-year grace period, and it was thought that in these 25 years, India will reform its laws on or bring about the modern laws and so on. But as it often happens in India, that things always take place at the last moment. In 84, they suddenly remembered कि 25 साल होने वाले हैं. Suddenly, a bill was drafted, presented in the parliament. If we remember the kind of composition of parliament in 1985, right? Brute majority for one particular party. So hardly any opportunity for dissent, any debate, any discussion. NDPS Act was actually formulated and passed without much debate and without much discussion. And soon after its passage, people realized that this has come about as a very draconian law, and because the passage of the law also coincided with the fresh epidemic of drugs entering in India. And that's why there have been 2 or 3 different occasions when some specific significant amendments have been brought to this law. But still, it is far from satisfactory. One aspect which urgently requires reform in the law is number one, to what extent the personal consumption of substance use should be criminalized. And that's on this view, I already talked about it. And it's fortunate now to note not just
us, the doctors, etc., or psychiatrists, but even the government departments. Ministry of Social Justice and Empowerment has officially written to the government that we want this amendment in the law that personal consumption of substances should not be criminalized. That's one way the law affects our patients. Another important way NDPS Act affect us psychiatrists is that many medicines which we use for treatment of mental illnesses as well as our colleagues use for treatment of pain, opioid painkillers, they are covered under the act. And since we always use these medicines in large quantity for treatment of our patients, we will always be treated as criminals, drug traffickers, or smugglers if we are found violating these acts, even inadvertently. So that's why one of the reform points in this act should be, and we have sort of officially written about it, that the law or the law enforcement authorities should treat what are known as legitimate entities handling narcotic drugs and psychotropic substances differently from the drug traffickers. So at this moment, the law applies similar if you are carrying one kilogram packet of morphine with you or a half a kilogram of buprenorphine powder with you, and if you are found carrying 1000 tablets of buprenorphine with you. But these two are very different kind of products and matters, and that's why not just doctors but even the producers, manufacturers, stockists, retailers, as well as us doctors should be treated differently by the law. That's one another piece of urgent reforms that we need. So these two I think need urgent reform under the NDPS Act. Unfortunately, we as collectively, as a psychiatric society, are still not have not warmed up our game on this. Like in MHCA, only after passage of MHCA, we started shouting, "Oh, हमसे तो पूछा ही नहीं, ये क्या हो गया?" That may happen with NDPS Act also if we do not get our act together. Thank you.
All right.
So just
Thank you,
add on,
sir.
सर के इसमें एक चीज है कि जो एनडीपीएस एक्ट है वो सेंट्रल गवर्नमेंट से पूरा ही होता है, अथॉरिटी जो है सिर्फ पुलिस डिपार्टमेंट इज अवेयर अबाउट एनडीपीएस एक्ट, बट द अदर डिपार्टमेंट्स लाइक अल्प्रेस गोली एनडीपीएस में अमेंडमेंट करके अभी बंद किया, लेकिन ऑल जीपीज आर प्रिस्क्राइबिंग थोरोली दैट अल्प्रेस टैबलेट, इवन नाइस गोली बहुत एनडीपीएस के ड्रग जो बहुत सारे प्रिस्क्राइब करते हैं। तो थोड़ा डिसेंट्रलाइजेशन करना चाहिए और स्टेट को भी कुछ रिस्पॉन्सिबिलिटीज देनी चाहिए। हर मंथली नार्कोटिक्स कंट्रोल ब्यूरो का मीटिंग होता है गवर्नमेंट अथॉरिटीज के साथ, जाते हैं सब लोग चाय पी के आते हैं, एवरी ईच एंड एवरी डिपार्टमेंट कम्स, बट किसी को कुछ उसके बारे में कुछ पता ही नहीं। और अमेंडमेंट करने के लिए जैसे सर ने कहा कि साइकियाट्रिस्ट लोगों का इन्वॉल्वमेंट भी उसमें होना चाहिए। उस एनडीपीएस एक्ट में एक दैट इज वन थिंग दैट इफ यू ट्रीट अ डी एडिक्टेड पेशेंट यू हैव टू इन्फॉर्म फॉर, जस्ट लाइक पोक्सो, पोक्सो की केस आती है तो आपने को इन्फॉर्म करना पड़ता है। सिमिलरली इन एनडीपीएस एक्ट इज देयर, NDPS Act में है सर। हाँ, so police has called me. You have to give the list of druggy patients from government institute to them so that they have check on it. So I think it's a very, we are treating them as a patient and they are treating them as a under trial criminals or anything. Then it will not happen to de-addiction properly. So such kind of amendment should be there.
Right. Right. So, Dr. Patel, we've been speaking about the NDPS Act and certain psychoactive substances, but nowadays more and more synthetic drugs are coming up into the market. I mean, we have adolescents or young adults coming in with very new and fancy names. So, can you please talk about management of such patients, or are there any protocols for management of such patients?
With respect to synthetic drugs.
Yes.
Yes. So, first of all, it is very hard to keep a list or prepare a list of what all uh, new newer psychoactive substances are being launched in the market or being used by the patient. So currently, under the name of newer psychoactive substances, we include them for the time being. Uh, Even there has been occasion when couple of my patients have told me so many new street names which I myself was not aware, and I might not still be aware about many of them. And but largely, if you want me to, categorize them, you can very well categorize one of the largest group called substituted amphetamines. So they are one of the category which were started manufactured, or again like Malay Davis sir was pointing out, like as a serendipity. So that was also accidentally being synthesized or discovered by Alexander Shulgin and the colleagues back in days. And because at that point of time they were facing a lot of uh, resistance from the authorities, they started trying it themselves, and they documented their experiences. So Dr. Shulgin has very nicely written two books. One is Fecal and one is Tikal, My Experiment with blah blah blah. And they're very good books if anybody has energy to read about. They're quite extensive documentation of his personal experience and entire journey. It started with an aim of helping patients in psychosocial intervention. Many a time, whoever have attempted, we do find that people with substance use disorder, we face resistance in therapy slightly more than patients with other psychiatric disorder like anxiety or mood disorder who are seeking treatment by themselves, rather than in substance use disorder who majority of them seek treatment because of initiation by family pressure or because of fear of marital separation or other more pressing psychosocial issues. So their expectation was that it helps in more connectedness. So they named it as empathogens, and then they thought that it will, if given in controlled doses in microdosing, it might help the therapist in conducting the therapy with patient. But eventually, from there, like any other psychiatric medication which is being misused or used for non-medical purposes at the time, has been started or launched with a tagline, it is non-dependent causes. And there is very negligible chance of habit formation. That is the tagline for almost major of the pharmaceutical drugs which you can think of and name of. Currently, that has been the largest share of the synthetic stimulants, even in the World Drug Reports last year as well, and this year also they released that is still leading the market share of last year's drug use in the current newer psychoactive substance category. Then followed that something called as hallucinogens, but again chemically, if synthetically we trace it back, again couple of substances lead to same synthetic substituents of amphetamines or stimulants. Then another major category comes as mephedrons. So substituted mephedron, synthetic mephedron, which is very, very prevalent in areas where like Mumbai, and might be also be witnessing a lot of this thing. So this is a brief background about what all synthetic drugs, apart from something called as synthetic cannabinoids. So synthetic cannabinoids, they are basically uh, they were came into the market with an effort to find a loophole. Like sir also mentioned that the biggest harm we can sustain from cannabis is criminalization. So synthetic cannabis, they are the perfect loophole in the legal system. They can be easily marketed through online digital platforms. Most of the time, they are marketed as quote unquote not for human consumption and as a essence. A, you can put it in some humidifier or something like that, bath salts, and then eventually people started using them. So we started seeing a lot of cases where the psychosis with respect to cannabis was even stronger, very resistant to antipsychotic medication, very difficult to control, and lasts longer. So the dictum goes, if you see a substance induced psychotic patient, you don't need to give antipsychotic, take out the substance, psychosis resolve. In few cases only, you need to continue antipsychotic. Here, we saw those psychotic episodes are more stable, they are longer lasting, and we are not very sure now that if this being synthetic drug induced psychotic disorder, do we need to stop it or do we need to continue? So these are the three major class of substances, among others, a lot of endless exhausting list, which are dominating the market right now. And then after this, what are the treatment protocol? So with respect to treatment, I would like to talk about management protocol. First is we need to identify what person is taking, because hardly patients come up initial phase when the acute period is going on, when we need to know the substance much more. We don't know about what patient is taking. So current acute management of such substances are based on symptomatic management. We don't have any facilities at majority of places, not at nodal centers. Like NDTC does have a good toxicological lab, but that is not present at almost majority of other places who are catering to substance using population. So that bypasses clinical discovery of what patient is taking as a clinical routine care. That is gone. We can just check a current clinical profile of the patient, clinically he's stable or not. We can, based on symptom, if patient is aggressive, choose your medication, either benzodiazepine or antipsychotic, or in some cases mood stabilizers, based on patient's profile, psychiatric history, and clinician's confidence with respect to one particular medications also. So that defines your choice. Over the time, no matter which drug, the acute phase will subside. Then the period comes. So what is different from other like conventional substance use and the newer synthetic substances are the option of having long-term maintenance medication, which I don't see in almost near future also we'll be able to be match up to the speed or rate at which the newer drugs are, or so-called psychoactive substances are being manufactured as compared to medications are being developed, right? So the only option which left with us is psychosocial intervention after the acute phase passes off. So if you see the current treatment or the human resource requirement with the ATF scheme of social justice also is availability of a counselor or a person having at least bachelor degree in psychology. That shows us the intent that why just talking about medication will not give us a holistic management package. And then from there, the discussion is boundless. You can talk about CBT approach, you can talk about relapse prevention therapy, you can talk about motivation enhancement itself or motivational interviewing as a skill to guide the entire treatment procedure without having much leeway or the options with respect to pharmacological treatment.
Right.
So that is with respect to how do we approach as of now the all the gamut of newer psychoactive substances.
Okay. Thank you for that comprehensive answer, sir. Moving towards my last two questions, I would like to come back to Ambekar, sir. Sir, please share your experience about, we've talked so far about psychoactive substances, different psychoactive uses. Can you please shed some light on behavioral addictions, internet use, screen addictions, gaming addictions?
So all the psychoactive substances on which we develop addiction, they act on our brain reward center, to put it simply, and that's how we develop dependence on them. That brain reward system can be stimulated by a variety of pleasurable behaviors, and there has been a raging debate to what extent the other kind of repetitive compulsive behavior which are pleasurable should be categorized as addictive behaviors. Number one, whether they are pathological or not. And number two, if they are pathological, are they more like impulse control or OCD problems, or are they more like addiction? So that debate had been ranging. To some extent, the debate got sort of uh, reached towards settlement when first DSM-5 in as gambling, and then ICD-11 agreed to include gaming and gambling disorders in the section of addictive disorders. So the contemporary understanding is that we mental health professionals must treat them as addiction and then should devise methods of treating them. Within our own fraternity also, there is a significant group of people, and outside our fraternity of course, who disagrees with this hypothesis that they are not addiction and they should not be managed as addictions. And but the reason behind they should be treated as addiction could be utilitarian as well. By utilitarian reasons I mean, if I am a department of psychiatry professor who need to employ a psychologist to provide treatment for behavioral addictions, and I need to create this post. I need to demonstrate that such a disease really exists for which I can create this post. An insurance company will reimburse the cost only if this is listed as a disease. If not, then you're just. So that's the reason why at this moment there is legitimacy for these two conditions. for a variety of other behaviors using digital technology, simply engaging with your screen or smartphone, then pornography, online shopping, social media. A lot of these ways in which we access, lot of these reasons for which we access digital technology, they are under the ambit of research to identify, to lay down the criteria whether they should be treated as addictions or not. So far, the progress, the state of the science, if we can call it, is that they, number one, there is some degree of consensus that two of them are indeed addictions and should be treated. How? There is exactly no clear consensus at this moment. Specific pharmacotherapy, no specific pharmacotherapy has been approved anywhere for these. Psychosocial interventions also, people are deploying the psychosocial interventions on the models of the way they were treating the substance use disorders. So the similar principles of motivation enhancement, cognitive behavior therapy, etc., are being employed for these as well. So this is simply a very growing field, a very open field, and people have been trying a wide variety of approaches. So no one can say with any degree of certainty that I have found the right answer. This is the package by which it should be treated. The way the confidence with which we can say benzodiazepines are the treatment of alcohol withdrawal. Opioid agonist maintenance is the standard treatment for opioid dependence. At this moment, there is nothing that we can say. So everything is sort of under trial and being researched. For other kind of addictions, for instance, screen, etc., to use the screen, mobile. At this moment, we do not even have authentic, credible, normative behavior guidelines. By normative behavior guidelines, I means, are there any authorities who are telling us to what extent your adolescent should be allowed use of screen, to how many hours a day is normal, how many hours after it becomes abnormal, and so on. So that also the consensus development process is currently ongoing.
Right.
Thank you.
Sir, are there any pharmacotherapeutic agents that you use or favor in such patients?
I look for the comorbid symptom profile and accordingly I decide. I will be very reluctant to start any medication solely for the purpose of so-called addiction to gaming, etc. If I expect that this patient is has more of a sort of a mm, anxiety type of symptoms, then perhaps SSRIs I would choose. There are patients in which I have tried naltrexone also, as in the hope that some of the craving anti-craving effect will work there. In some patient it has worked, in others it has not. So I do not have any definite answer to this.
And these
I'm
are all
afraid.
adult patients, like above 18 or
Adolescents, late
adolescents.
adolescents.
Okay. All right. Thank you, sir. And my last question for the session for Dr. Busare. Sir, are there any current aftercare programs or follow-up protocols which exist to follow up patients who've been discharged from rehabilitation facilities?
Aftercare program as such for the care given after the discharge from the rehabilitation center or mental health establishment. As such, there is a aftercare program is not there, but follow up. We advise patient to follow up monthly regularly. Then we have the 12-step program is there from the de-addiction centers. The patient is follow. There is community meetings like Alcohol Anonymous and Narcotic Anonymous, and that meeting they should have attended. As it should be developed, aftercare program should be developed from each and every center and government also. We can take help of telemanas. That telemanas is 14416. That government is toll free number. It is for creating awareness about mental diseases or mental illnesses, and to take any kind of mental help. It is available 24/7. So we can definitely take help of that telemanas number to create aftercare program from the any institute of government center, and we can tie up with them. And that, as sir has told, there is one staff from there. They daily used to call their relatives and patient, कि सुबह पेशेंट को फोन करेगा और रात में रिलेटिव को फोन करेगा. तो इतना भी नहीं हुआ तो एटलीस्ट आफ्टर 8 or 10 days we have to take call. There is a aftercare program, all these things.
So mostly it sounds like patient or family initiated aftercare rather than a caregiver provided aftercare.
Family care में उसमें family meetings will be there, and then we will ask them.
All right. Thank you so much, sir. Thank you. A big thank you to all the speakers for your wonderful uh, sharing all the knowledge that you have. And I'm sure everybody in the audience has benefited immensely from whatever they've heard from you today. We've included audience questions in the session as well. So I think we'll call it a day. Over to the master of the ceremony.
I would like to thank our distinguished panelists and our moderator for shedding light on the complexities of addiction medicine. Your insights into the challenges and realities of clinical practice have been truly inciting. Uh, I would now like to invite Dr. Pavan Adatya to felicitate the panelists.
Moderator, I think. Very effective. Ah, good. इसके बाद valedictory हो गया
Thank you, sir.
हो गया मेरा बार हो गया इसमें नहीं करेंगे
So, as we come to an end to this academic feast, we now begin the valedictory session, for which I would like.
आपको आना पड़ता उधर बैठा वो को मिलाना है जैसे मैं का
I would now like to invite a few of the attendants of today's conference to give a few words about their experience. The first one is Dr. Jeel Vasa, third year resident at AIIMS.
Good afternoon, everybody. My name is Dr. Jeel. I'm a JR3 here at AIIMS Nagpur. This morning has been a wonderful Sunday for all of us. It was great weather and even better conversations today. It started off with the esteemed panelists today, and it started off with a wonderful session by Dr. Ambekar sir. And then we went into the practicalities, but not forgetting that at the end of the day, we are students of science by the sessions by Dr. Dave sir and Dr. Patil sir. The panel discussion also was very, very informative for all of us junior residents, and we are very grateful to the entire team for organizing this CME for us. Thank you very much.
Thank you, Jeel, for those very kind words. I would now like to invite Dr. Akash Kumar to also give a few words.
Good afternoon, everybody. I am Dr. Akash Kumar, Assistant Professor in Department of Psychiatry, AIIMS Raebareli. So I'm also in charge of addiction treatment facility there. So my purpose of coming to this CME with the expectations of getting to know and getting more knowledge from the experienced and esteemed speakers which are present here today. And truly, my all expectations have been satisfied. This one-day session of CME is rich in knowledge, rich in experience of such faculties from all over India, of course. Also, I would like to congratulate the organizing team, the Department of Psychiatry of AIIMS Nagpur, for giving us this opportunity and conducting all the sessions very smoothly All the sessions, speakers, the quality of the lecture, the quality of the session was very crisp and very informative. This also raises our expectation from AIMS Nagpur team to further organize more CMEs and more workshop on addiction in future. Thank you.
Thank you for your kind words, Dr. Akash. I would now like to invite Dr. Gaurav Singh, our organizing secretary, to give the vote of thanks.
Respected dignitaries, esteemed guests, faculty members, and participants, it's my privilege and honor to deliver the vote of thanks on behalf of the Department of Psychiatry, AIMS Nagpur, at the conclusion today's CMEs on addiction medicine. At the outset, I extend my deepest gratitude to Professor Dr. Prasant Joshi sir, Executive Director, AIMS Nagpur, for his gracious presence and unwavering support. His constant encouragement and visionary leadership have been instrumental in making this academic initiative possible. I express my sincere thanks to Dr. Sudhir Bhave sir, President Psychiatric Society West Zone, and Dr. Priti Bhute ma'am, President Psychiatric Society of Nagpur, for their collaborating with us for this CME and their kind presence and thoughtful insight which enrich the proceedings of this CME. My deepest gratitude to our distinguished speakers, panelists, and moderator, Dr. Atul Ambekar sir, for sharing his immense uh, expertise in the field of addiction medicine. Sir, your insights were not only academically enriching, but also deeply practical and relevant to current clinical challenges. We are sincerely thankful and would look forward to your continued guidance, sir. I would also like to thank Dr. Maladev sir, Dr. Suresh Patil sir, Dr. Amol Dusare sir, Dr. Vineet Patel from AIMS Raipur, Dr. Manish Thakre sir, Dr. Abhijit Fai sir, Dr. Rahul Tadke sir, Dr. Vikas Bhute sir, Dr. Nikhil Pandey sir, and Dr. Neha. I would also like to thank Dr. Suyog Jaiswal, organizing chairperson, for his vision, dedication, and meticulous planning, which laid the foundation for the success of this event. Special thanks to Dr. Ashish Kuthe sir, treasurer, for handling the logical aspects and coordination seamlessly, and to Dr. Abhijit Faiser, scientific chairperson, for his active role in organizing and facilitating today's proceedings. I would also like to thank Dr. Bhavika and Dr. Soumya Jha, who were the master of ceremonies for the today's event. My heartfelt appreciations to the entire team of our Department of Psychiatry, Dr. Sri Lakshmi ma'am, Dr. Chitej, Dr. Ayushi, and for our junior residents who have done a very good job behind the scene works to ensure the smooth execution of the CME. A special thanks to our addiction treatment facility staff members. I would also like to thank Manoj Singhi and team for the technical support and necessary arrangements. I would also like to thank INTAS division, Aviana division, for the support. I would also like to support the staff member of from AIMS Nagpur. Lastly, I would like to thank all our delegates, participants for your enthusiastic involvement and keen engagement. Your presence and participation made this academic event vibrant, insightful, and truly meaningful. Thank you all once again for your valuable contribution. Thanks a lot.
Thank you, Gaurav, for such a comprehensive thank you. So I just wanted some of our senior colleagues to share a few comments.
Yeah. Thank you, Suyog. Uh, it was a very much needed topic of addiction that was comprehensively covered in this CME. I think in analogy term, I would say Ambekar sir played like Virat Kohli till the end, and the way sir like always being a technical like he played like David, enlightening us on various finer aspects of the drug endoxifen. Dr. Suresh played like Surya Kumar Yadav, very unconventional ways of presentation and practical approach uh, to build his innings and giving finally a result and of winning the match. And Dr. Amol and Dr. Vineet added flavors in the middle order. Uh, and enlightened us with their practical and theoretical knowledges related addiction. So now we are actually more getting more addicted to AIIMS Nagpur's educational drive and their frequent programs. So congratulations, sir. Thank
Thank you. Just last few words. Kudos to Dr. Suyog Jaiswal, Dr. Sri Lakshmi, and the AIMS team. Since AIMS has been set up, this team has been a huge asset of the Psychiatric Society Nagpur also, and now it confirms means the kind of speakers they have got, the kind of topics they have covered. Uh, it was a huge value addition. So thank you. It was such a sweet, short and sweet program, but it takes huge efforts to organize something like this. So kudos to you. Thank you.
I would once again like to thank everyone for attending this enriching event. Let's carry forward the insights shared today into our practice and advocacy for a better addiction care. Now, I would like to request everyone to kindly proceed for lunch.